are you working?
I'm Priyanka. I'm 23 years old. I'm living in Hyderabad, India. ఇండియాలో చాలా వరకు తెలీదు. కొన్ని ప్లేసెస్లోనే ఈ సికిల్ సెల్ అనేది తెలుసు కొంతమందికి. నాకు 2016లో డయాగ్నోస్ అయింది. అప్పుడు ఇది సికిల్ సెల్ అనేమియా అని చెప్పినప్పుడు అది ప్రొనౌన్స్ చేయడానికి కూడా రాలేదు నాకు. అసలు ఈ సికిల్ సెల్ అంటే ఏంటి, ఇది ఒక కొత్త వింతగా ఉంది, ఇది ఉంటుందా, అసలు ఇట్లాంటివన్నీ ఉంటాయా అని కూడా అప్పుడు కొంచెం తెలియకుండా ఉందన్నమాట. తెలియలేదు అసలు ఇది ఒక డిసీజ్ అని కూడా తెలియదు.
How painful is sickle cell disease?
ఇంకా చిన్న ఇట్లా కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వస్తుంది. పెయిన్స్ వచ్చినప్పుడు అంటే హ్యాండ్ కూడా కదపడానికి రాదు. హ్యాండ్ పెయిన్ వచ్చినప్పుడు లేవడానికి రాదు, నడవలేము, ఏమీ పట్టుకోవడానికి రాదు. ఆ పెయిన్ వచ్చే టైంలో ఎక్కువ పెయిన్ వస్తున్నప్పుడు బ్రీత్ కూడా చాలా కష్టంగా ఉంటుంది. ఇట్లా కదపడానికి కానీ అసలు కొంచెం ఇట్లా ఎవరైనా బెడ్ దగ్గరికి వచ్చి బెడ్ కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వచ్చేది. అసలు తట్టుకోలేనంత నొప్పి వచ్చేది. ఈ పెయిన్ ఉన్నప్పుడు ఎప్పుడు చేసే పనులు కూడా చేయలేము, డైలీ చేసుకునే పనులు.
So, are you working at the moment?
3 months నుంచి నేను పెయిన్స్తో ఉండడం వల్ల వర్క్ చేయలేకపోతున్నా. దానివల్ల శాలరీ లేదు. ఇప్పుడు అట్లా శాలరీ అమౌంట్ లేకుండా ఉండడం వల్ల ఇప్పుడు బయటకి ఎక్కడికైనా వెళ్ళాలనుకున్నా ఫైనాన్షియల్గా ఈ ప్రాబ్లం ఉండడం వల్ల వెళ్ళలేము. ఒకవేళ ఏమైనా తినాలనిపించి కొనుక్కోవడానికి కూడా కష్టంగా ఉంటుంది. ఏమన్నా చెయ్యాలి అనుకున్నా అది చేయలేము. అంటే ఫైనాన్షియల్గా అంటే డిపెండ్ అవ్వాలి, వేరే వాళ్ళపైన డిపెండ్ అయ్యి చేసుకోవాలి. మనం సొంతంగా చేసుకునే పని కూడా చేసుకోలేము. I'm Priyanka. I'm 23 years old. I'm living in Hyderabad, India. ఇండియాలో చాలా వరకు తెలీదు. కొన్ని I'm Priyanka. I'm 23 years old. I'm living in Hyderabad, India. ఇండియాలో చాలా వరకు తెలీదు. కొన్ని
नाम है लवली, मैं 20 साल की हूँ और मैं उड़ीसा से हूँ और मुझे सिकल सेल, हम 2 भाई 2 बहन हैं। तो भाई दोनों पॉजिटिव में अच्छे हैं और दोनों बहन को सिकल सेल ब्लड उसके अंदर 4 पॉइंट ही था, इसलिए दीदी गुजर गए। मुझे जब मालूम हुआ 12 थी मेरी उम्र, सिकल सेल हुआ है बोलकर सर।
How are you affected by sickle cell disease?
मैं बार बार बीमार हो जाती थी, बहुत बार मुझे हेल्थ इश्यूज होता था और पेन्स भी बहुत होते थे जब मेरा तबीयत खराब होता था। तो देखो, जब तो मेरे को स्टार्टिंग जब हुआ था तो बहुत तकलीफ होता था, पूरा जॉइंट्स पेन होता है, ये फुल पेन होता है। हेल्थ इशू होता है कि कहीं हम मर जाने वाले हैं। मेरे पास कुछ वर्क करने को मुझे मन ही नहीं होता था, सांस चढ़ जाती थी। तो ऑक्सीजन लंबा लेते हैं तो अभी तो भी जान जाएगी ऐसा टाइप लगता है फील। जब उठ के नहीं चल पाते हम अपनी हालत में नहीं रहते, तो मम्मी ही वॉशरूम को लेके जाती थी मुझे उठा के।
Tell me about a sickle cell crisis.
जॉन्डिस स्टार्ट होने के बाद है ना, आंखें पीले हो गए और बुखार जल्दी आ जाता था, हेडेक फुल होता था। कुछ नहीं है बोलने के लिए, मतलब उतना ही हेल्थ इशू होता है। जब हम सोते हैं तो ऑक्सीजन लंबा लेते हैं, ब्लड इमीडिएटली कम हो जाता है। मतलब अभी वो भी बोलूँ क्या, लास्ट टाइम पे 4 पॉइंट हो गया था मेरा हेमोग्लोबिन। फॉरनली हॉस्पिटल पे आके जब मैं मरने वाली बची।
And what would you say the impact of sickle cell disease has been on you?
मैं बार बार बीमार पड़ जाती थी और मेरा तबीयत बहुत ख़राब हो जाता था। तो पापा है ना, जो मतलब उधार को भी लाके हमें ट्रीटमेंट किया है पापा ने। पापा के बिजनेस में तो सर मेरा जितना पहले तो नहीं मालूम था, तो पूरे बाहर ट्रीटमेंट करते थे तो पूरा अमाउंट ख़त्म हो गया। फिर पापा का शॉप भी बंद कर दिए, तो बहुत मैनेज कर देते थे, पर बहुत ज़्यादा हमने स्ट्रगल किया है सर। और मैं उम्मीद हार चुकी थी कि मैं नहीं जिंदा रहूंगी बोलकर, और उसके बाद मैं उम्मीद नहीं हारी और है ना जॉब पे स्टार्ट करी मैं जॉब जाना। जब मेरा हेल्थ थोड़ा अच्छा हुआ तो अभी मैं घर भी देख रही हूँ, घर भी मैं ही चलाती हूँ अब।
So you managed to turn it all around.
जब हेल्थ इशू आता है तो नहीं रहता है, ऐसे तबीयत में भी जाके मैं जॉब करके आती हूँ।
If you could say one thing about sickle cell disease that you want other people to know, what would you say?
छोटे बच्चे भी रहने दो, मेरे उम्र के भी रहने दो, मैं अभी जॉब भी करती हूँ। मेरा हेल्थ इतना इश्यूज था पर अभी कुछ भी नहीं है प्रॉब्लम। घर भी मैं चलाती हूँ, मॉम डैड भाई लोगों को देखती हूँ। ऐसा मत समझो कि हम सिकल सेल है कि हम कुछ भी हम कर लेंगे, आवारा फिरेंगे। ऐसा मत सोचो कि आप लोग ही बहुत टैलेंटेड रहते हो। सिकल सेल लोगों को ज़्यादा ही दिमाग रहता है, बहुत फर्स्ट रैंक में पास होते हैं। थैंक यू।
I'm Priyanka. I'm 23 years old. I'm live in Hyderabad, India. ఇండియాలో చాలా వరకు తెలీదు, కొన్ని ప్లేసెస్లోనే ఈ సికిల్ సెల్ అనేది తెలుసు కొంతమందికి. నాకు 2016లో డయాగ్నోస్ అయింది. అప్పుడు ఇది సికిల్ సెల్ అనేమియా అని చెప్పినప్పుడు అది ప్రొనౌన్స్ చేయడానికి కూడా రాలేదు నాకు. అసలు ఈ సికిల్ సెల్ అంటే ఏంటి, ఇది ఒక కొత్త వింతగా ఉంది, ఇది ఉంటుందా అసలు, ఇట్లాంటివన్నీ ఉంటాయా అని కూడా అప్పుడు కొంచెం తెలియకుండా ఉందన్నమాట. తెలియలేదు అసలు ఇది ఒక డిసీజ్ అని కూడా తెలియదు.
How painful is sickle cell disease?
ఇంకా చిన్న ఇట్లా కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వస్తుంది. పెయిన్స్ వచ్చినప్పుడు అంటే హ్యాండ్ కూడా కదపడానికి రాదు. హ్యాండ్ పెయిన్ వచ్చినప్పుడు లేవడానికి రాదు, నడవలేము, ఏమీ పట్టుకోవడానికి రాదు. ఆ పెయిన్ వచ్చే టైంలో ఎక్కువ పెయిన్ వస్తున్నప్పుడు బ్రీత్ కూడా చాలా కష్టంగా ఉంటుంది. ఇట్లా కదపడానికి కానీ అసలు కొంచెం ఇట్లా ఎవరైనా బెడ్ దగ్గరికి వచ్చి బెడ్ కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వచ్చేది, అసలు తట్టుకోలేనంత నొప్పి వచ్చేది. ఈ పెయిన్ ఉన్నప్పుడు ఎప్పుడు చేసే పనులు కూడా చేయలేము, డైలీ చేసుకునే పనులు.
So, are you working at the moment?
3 months నుంచి నేను పెయిన్స్తో ఉండడం వల్ల వర్క్ చేయలేకపోతున్నా. దానివల్ల శాలరీ లేదు. ఇప్పుడు అట్లా శాలరీ అమౌంట్ లేకుండా ఉండడం వల్ల ఇప్పుడు బయటకి ఎక్కడికైనా వెళ్ళాలనుకున్నా ఫైనాన్షియల్గా ఈ ప్రాబ్లం ఉండడం వల్ల వెళ్ళలేము. ఒకవేళ ఏమన్నా తినాలనిపించి కొనుక్కోవడానికి కూడా కష్టంగా ఉంటుంది. ఏమన్నా చెయ్యాలి అనుకున్నా అది చేయలేమంటే ఫైనాన్షియల్గా అంటే డిపెండ్ అవ్వాలి, వేరే వాళ్ళపైన డిపెండ్ అయ్యి చేసుకోవాలి. మనం సొంతంగా చేసుకునే పని కూడా చేసుకోలేము.
Please go ahead, sir.
Good evening, friends. On the occasion of World Sickle Cell Day, that is 19th of June, we are privileged to have this scientific event to take a stock of situation and also to see what may be happening in the field of sickle cell disease in future. We have an elaborate program laid down with the help of Mumbai Hematology Group and Novartis, which will go right up to 9 p.m. this evening. Sickle cell disease is an important genetic issue, not only in this country, but all over the world. Because of the migration, there's hardly any part of the world which has sort of escaped from this dreadful genetic disease. And I say dreadful because it not only creates a lot of morbidity, it also shortens the life. It has not been easy to control this particular disease. From neonatal screening program, improving the nutrition, folic acid supplement, control of infection, use of vaccination, hydroxyurea, right up to the development of various newer molecules that have modified the disease course, especially with the introduction of crizanlizumab in this country. There has been a research of scientific activities which have brought the like-minded people together to see what more can be done for the unfortunate victims of this disease. Today, in the first half of the session, that is from 4 o'clock to 6 o'clock, Dr. Shashank and Dr. Aditya from Novartis will be anchoring the program, and we have 3 wonderful speakers from Jharkhand, from Gujarat, and from Odisha to take a stock of situation of what is happening at the state level and what initiatives have been taken. I'll be back with you at about 6 o'clock for conducting the scientific event, and I'm sure that both these will be very, very important milestones in uplifting the care of sickle cell disease in this country. So I hand over the platform now to Novartis to conduct the same.
Thank you very much, sir, for the introduction, and wishing all, today is a World Sickle Cell Day, so thanks to all of you for joining, and thank you, Dr. Agarwal, sir, for setting the context and setting the platform. So we now, as sir mentioned, that for the perhaps next 2 hours, we'll be having a state level scenarios as well as the initiatives taken by 3 of our states. So now I request maybe Aditya or Shashank to introduce the first speaker, and then we go ahead. Is that okay, sir?
Absolutely.
Sure, sir.
Hello, sir. Thank you so much for this opportunity to introduce the speakers for the prestigious meeting that's happening today. Let me just switch to video. So I'm very privileged now to introduce the first topic of the meeting, that is the state level scenario of sickle cell disease and the initiatives at various states that has been taken. So to start the first talk, I would like to invite Dr. Anupa Prasad, who is Associate Professor of Biochemistry Department and Head of the Department of Genetics and Genomics, Jharkhand. I welcome you, ma'am, and the stage is all yours.
Thank you. Thank you for the introduction. And at the outset, I would like to thank Mumbai Hematology Group and Novartis for giving me an opportunity to speak on this important platform on this important day, that is Sickle Cell Anemia Day. And I would be talking about sickle cell disease in Jharkhand. So the agenda will be burden of sickle cell disease in India and in Jharkhand, healthcare disparities and challenges of sickle cell disease patients, and impact of sickle cell disease and vaso-occlusive crisis in terms of mortality, complications, quality of life, and economic impact. So the distribution of sickle cell anemia is restricted to certain geographical specific geographic locations. Prevalence of sickle cell carriers among general population is marginal. However, the prevalence among tribal population in different states in India is 1 to 40%, highest being in central India. Nigeria, Democratic Republic of Congo, and India account for 57% of newborn with sickle cell anemia, and the number is going to be approx 16 lakhs by 2050. The global burden of sickle cell anemia is rising, highlights the need to develop appropriate public health planning, particularly in low and middle income countries. And about 1.4 million people in India have sickle cell disease. This depicts a huge burden. So HBS is unique in occurring predominantly in endogamous native tribal populations, and limited studies from the eastern and northeastern parts of the country are available. There is paucity of data from Jharkhand. High frequency of HBS among tribals conforms to the existing knowledge about HBS. However, the observations made in Jharkhand by Nagar et al. Tend to deviate from the prevailing view about tribals as well as HBS. So it was a study in 2015 where frequency was 13% in Chhattisgarh and 3.3% in Jharkhand. However, this study highlighted that the areas adjacent to or the district adjacent to this Chhattisgarh and Odisha in Jharkhand had higher frequencies. So we have a DBT Umid program going on in Ranchi district, and we screened out of 5393 antenatal women that we screened. There were a total of 211 sickle cell trait positive, sickle cell trait, and 17 sickle cell disease patients. So in Ranchi district, we can say that the sickle cell gene prevalence is 4.2%. And when we see the tribals prevalence, the sickle cell gene prevalence in tribals was 7.27%. So, and in our study, tribals constituted 49% of the sickle cell anemia patients, followed by Muslims. So when we compare the previous study data and the present data, we find that there is a higher prevalence of sickle cell in total population as well as among tribals. We got till now we got a number of sickle cell gene mutation positive couple. What we do, we actually screen antenatal women. If they are positive, we recall them along with their spouses, counsel them, and then we do tests for the spouses. And if they are also found positive, we do mutational analysis. For if both the couples are positive, then we do prenatal diagnosis for them. And currently prenatal diagnosis is being offered at MAMC New Delhi. It is Dr. Seema Kapoor's. Dr. Seema Kapoor from MAMC is the PI of the project, and the facility is going to start soon at RIMS Ranchi. Through the DBT Umid initiative, we have been able to prevent birth of at least 6 homozygous sickle cell disease children. So this is the picture that was given by Kolar et al. In 2015, and it was said that Jharkhand has less than 5% of HBS rate. So I would, from our study, when we publish it, maybe we can say that this comes to a green circle, with the prevalence lies between 5 to 10%. And now that we have seen that Jharkhand has, central Jharkhand, actually Ranchi is in central Jharkhand. So central Jharkhand has relatively higher prevalence than previously quoted. And we want to screen the adjacent areas of Chhattisgarh and Odisha, and then we can quote, we can say something better on this aspect, whether they have higher, what kind of prevalence is there. Then coming to impact of SCD on quality of life, work and daily activities, it's involving physical, psychosocial and cognition. All the domains, everyday activities affected, and most of the patients feel sad and disinterested. There is lack of actually awareness in all the districts. So impact of SCD on patients, there is, because of the lack of awareness, there is high and early mortality. So common causes of death in SCD in clinical practice at RIMS is acute chest syndrome, infection, vaso-occlusive crisis, anemia, stroke, and splenic sequestration. Patients have voices, they have pain everywhere, they complain that they never got to know that the correctly about sickle cell disease, and that's why they got delayed treatment. It really impacts basic day-to-day activities, and most important, that we did not know earlier that the painful events could be prevented. So we have to be like proactive in providing information, education, and communication to the patients. So there are insights from patients and insights from caregivers. Pain crisis is there, affecting physical health, mental health, and needing opioid use. Range of acute adverse events are there, and accumulated acute effects are there, which lead to long-term organ damage. So SCD patients face extraordinary challenges and barriers. It remains misunderstood and marginalized because different patients present differently, and there is a huge economic impact because of this. So the need for sickle cell disease patients in Jharkhand is implementation of information, education, and communication, implementation of antenatal screening in all the districts, and establishment of a platform for prenatal diagnosis. Newborn screening programs are needed, and most important, provision of hydroxyurea, folic acid, antibiotics, and vaccinations to the diagnosed patients. We also need to have a bone marrow transplant center. Important perspective of sickle cell disease is that it remains a misunderstood condition in terms of clinical presentation and prognosis. Sickle cell anemia patients registry has recently started at RIMS. We have till now registered 75 patients, and we hope to get a good number in our registry soon. So the summary of my talk is that the burden of sickle cell disease is high in India, including Jharkhand. Considering approx 50% of the sickle cell disease patients belong to the tribal communities and low SES, they face significant healthcare challenges and disparities, from basic facilities of hygiene to every step of diagnosis to management. Sickle cell disease significantly affects quality of life and impacts education and work. Mortality and complication rates among these patients are high and most commonly observed in 4th to 2nd second to fourth decade, depicting severe disease. So, and VOC, ACS, anemia, and infections remain a major cause of mortality among our patients with sickle cell disease. And this is a severe phenotype of the disease. We need to study further. So with this, I would like to stop here and thank you all for listening.
Thank you. Thank you so much, Dr. Anupa, for that lucid presentation on the situation of sickle cell patients at Jharkhand and very clearly highlighting the facts from screening to mortality and also bringing up the key points on challenges with quality of life of patients living with sickle cell disease in Jharkhand. And now I would like to invite Dr. Umang Mishra, who is from the Ministry of Health and Family Welfare, Government of Gujarat. His work in Gujarat state in sickle cell disease among sickle cell disease patients and hemoglobinopathies is very well known. Now I would hand it over to you. The stage is all yours, sir.
Thank you very much. I am very grateful to Mumbai Hematological Group and Novartis for giving me such opportunity on the day of this World Sickle Cell Day. I first congratulate all the sickle cell warriors who are present here and listening from this platform, and congratulate all the sickle cell disease and pray for them. And yeah, can you see my screen?
Sir, it's not visible yet. We can see the folder of your presentations. The PowerPoint has not, it's not come out yet.
Now is it visible?
No, sir, not yet.
Now is it visible?
Not yet.
No, sir, not yet.
Just a minute, just a minute.
Please share it again.
Yes, yes. Now, is it visible?
Yes.
Yes.
Sorry for inconvenience.
Yes. Make it full screen. Yes. Go ahead, please.
Fortunately, now I am not with the sickle cell anemia control program in Gujarat since 3 to 4 months, but by heart I am with the sickle cell disease patients every time, and Novartis persons regularly meet me for that. As Anupa Madam says, and we all know that the sickle cell is a major public health problem in the world and especially in the India. And it is mainly seen in the tribal, which is medically underserved and in the lower socio-economic class. And more than 50% of the sickle cell disease patients live in the India. So we have to look further for this program in the past, and most of the deaths in the sickle cell disease occurs during the first 5 years of the life. If patient also survives, the risk of the disease seems, and as ma'am says, the risk of the severity of the disease in the third or the fourth decade become very severe when he or she is in economically earning period. And sickle cell anemia has not gained much attention still in 21st century in 2022 from the national level. As such, other program has gained like TB, malaria, but sickle cell anemia has not. Even thalassemia has gained so much attention, but sickle cell disease has not gained so much attention from the national level. And management of the sickle cell anemia is missed by the many practitioners. As Madam said, in the Jharkhand, it is missed many times in the practitioner. Even in the Gujarat earlier when we have started the program, the sickle cell anemia was misdiagnosed and mistreated even by the tribal doctors, even by the tribal medical officers. They diagnose the sickle cell anemia is a iron deficiency anemia, and we could not treat the patient, and we had a higher mortality rate at that time. And screening is not a common practice. Even today, patient go to the hospital, and diagnosis for the sickle cell anemia, screening for the sickle cell anemia in the private is not a common practice, even in the other part of the country. And many communities in the tribal areas in the country are still untouched in many states. If we talk about the Gujarat, Gujarat has 14% tribal population against other states. Other states have the 7% of the tribal population. So we have the double the proportion of the tribal population, and the 45% of the population are the below the poverty line. Poverty, illiteracy, tribal residing in this the underserved remotest area from the main city, main medical colleges, and the tertiary care centers. Hence, this they were misdiagnosed and mistreated, as the clinician were also unaware that sickle gene amongst them. And so we need a specific public health program like the another national health program like TB, malaria, and other vaccination program, which specifically target this tribal audience and treat this sickle cell anemia. So in the year of the 2006, when our Honorable Prime Minister was our CM, Chief Minister, he has launched the sickle cell anemia control program in our government setup as a control program on PPP mode, government and non-government partnership in the most affected 5 districts of the South Gujarat, and then extended to the remaining all tribal districts of the Gujarat in 2008. All 14 tribal districts of the Eastern Belt are affected by the sickle cell anemia in the Gujarat. We can see in the picture that all 17 districts from the north in Banaskantha adjoining to Rajasthan, and south in the Dang and Valsad, all are affected in the Eastern Belt. Most of population in this area are tribals, and they live in the dense forest area mostly. Our main program goals were the prevention of the sickle cell disease childbirth, and the prevention of the death from the sickle cell crisis, and improve of the health status and the quality of the life of the sickle cell disease patient. So objective of the policy was the reducing the burden of the sickle cell anemia by increasing the productivity, longevity, and the quality of the life by gaining the screening, early diagnosis, prompt treatment, and counseling, by preventing the transmission of the disease to the next generation, to reduce the morbidity and the mortality among the tribal population from the sickle cell anemia. This is the progress of the sickle cell anemia control program. In 2006, as I said, the program was started. In 2000 and extended to the remaining nine districts. In 2011, we had made a autonomous Gujarat Sickle Cell Anemia Control Society. This is the major administrative problem, achievement and steps taken by the Gujarat government to form a Gujarat Sickle Cell Anemia Control Society, and to integrate the efforts by the different departments, and to start all the steps very quickly. And in 2012, entire the tribal population, we have outsourced the outsource the screening program to the 7 qualified, competent and dedicated competitive agencies like the Valsad Ragdan Kendra, Indian Red Cross Society, Hindu Blood Bank. We thought that this is the genetic disease and the burden of the disease will be increasing day by day if we do not take any concrete steps. And we have to identify all the disease patients at the early stage. So we thought to screen all the patients, and we go to the village level to the patients to the village level to the persons and screen them and identify more than 30,000 patients today and more than 7.5 lakh sickle cell trait to whom we can counsel and treat very regularly. In 2015, prenatal diagnosis was initiated. 2017, we implement pneumococcal vaccinations for the sickle cell disease patient. And 2021, daycare treatment center, comprehensive center were started at Surat and Valsad, and another 3 centers started this year at Valsad, Navsari and Dan. The component of our program are the early diagnosis, the prevention, management of disease, and the capacity building. Any disease can be prevented and treated, and any mortality or morbidity can be reduced by the early diagnosis. So early diagnosis are achieved by the adolescent screening, antenatal screening, prenatal diagnosis, and the newborn screening. As I said earlier, mass screening on the mission mode, especially done in the 2012, covered the screening of the 8 million people population in almost only in the 3 years. We also have Mamta Divas weekly immunization day for the all antenatal mothers. So all antenatal mothers in the tribal area are screened for the sickle cell anemia, and if mother found positive, her husband is also screened, and if husband and wife both are positive for the sickle cell gene, they are advised for the prenatal diagnosis and counseled, and if they agree, then newborn they agree, prenatal diagnosis is done. Newborns are screened for the sickle cell anemia after birth by the HPLC method. Prenatal diagnosis is done at the private lab in the Surat, Ahmedabad, and Baroda. Sampling is done by the CVS or the amniocentesis, and we are planning to develop a center at the new civil hospital Surat also. The prevention by the pre-marriage counseling, genetic counseling, building community awareness, which is a very important part of the program, and the IEC and the IPC. Prevention, we have the dedicated district nodal officer in all the district who looks after the sickle cell anemia control program, every activity. At state level, we have deputy director level, the state nodal officer. We have 180 sickle cell counselor from the NHM support, almost 1 counselor between 2 primary health center in the tribal area, and personal contact with each sickle cell disease patients on the monthly basis, monthly visit by the counselor. And in case we have many patients, and if any counselor cannot go to the patients monthly basis, we can contact them through the telephone also, which establish the good rapport between the patients and the counselor. And the counseling and training have been given to the all teachers and students in the ashram sala and the college in tribal blocks with the help of the tribal development department in the Gujarat. Management, we give the supportive treatment, regular follow-up, and the daycare, advanced tertiary care center, and the life-saving drugs like hydroxyurea, crizanlizumab, and the vaccination. We have developed manual for our medical officers and the doctors in the at the PSCs, CSCs to treat the complication of the sickle cell anemia, and develop the manual for our FHW, ANM, and the ASA worker in vernacular language, how to communicate with the sickle cell disease patients and how to counsel them and how to teach what are the complications of the sickle cell anemia. We offer the free treatment to the SCD patient at PSC level, CSC level, district hospital level, free hydroxyurea tablet for sickle cell disease patient up to the PSC pneumococcal vaccination, free blood transfusion, quarterly free medical checkup at block level, and guideline is developed such a level that primary, secondary, and tertiary level treatment is how is given, and regular counseling and free tablet folic acid for daily taking for daily to all sickle cell disease patient. Capacity building of all doctors, paramedical staff, and the healthcare workers, including the private doctors through the IMA, ASA, Anganwadi, and teachers, and also social and political leaders, which are the main part in the tribal community. Our journey so far in the last decade, more than 11 million population have been screened in tribal area. Tribal population as well as the other than tribal population also have been screened, of which 7.46 are the sickle cell trait, while 31,000 are diagnosed with the sickle cell disease. This year, more than 10,000 sickle disease patients have treated with the sickle cell crisis, major and minor both. More than 22,000 patients have been vaccinated with the pneumococcal vaccine, and more than 5,000 patients are on the tablet hydroxyurea, and they are given at their doorstep on regularly from the PSC level. And as of now, almost more than 4,000 prenatal diagnosis has been done, and due to this, the 613 sickle cell disease births have been prevented from the prenatal diagnosis. This is the facilities have been developed. Primary screening is available at more than 2,700 center in tribal area, PSC, CSC, and health and wellness center, 7 HPLC center in the government, 4 dedicated treatment center, 3 prenatal diagnostic center, and 180 dedicated sickle cell counselor, which are either MSW or Master in Psychology. We have the comprehensive sickle cell clinic to provide the free of cost treatment at in tribal and rural area, which provides the primary screening, marriage counseling, all the treatment and counseling and preventive activities and diagnostic activities at one center for the sickle cell disease patient. We have developed such a comprehensive sickle cell clinic, first at the Rumla in the Navsari, then in the Valsad, Dharampur in the Valsad, and then in the Vasta, and now in the Dang. This type of cards, yellow cards, half yellow cards, and white cards are given to the normal trait and disease patient. Special features of this program, that regular counseling at the doorstep of the beneficiary. Our counselor go to the sickle cell disease patient at their home and give the counseling at their doorstep. Daily folic acid supplementation to all sickle cell disease patients to prevent anemia. Life-saving hydroxyurea, treatment guideline, program manual for the healthcare worker and ASA, and the prenatal diagnosis are the special features. The most special features of this program, that life cycle approach. We screen the newborn screening. We cover the adolescents. We cover the antenatal, and we have covered entire the life cycle approach in our screening and preventive and treatment part. We active involvement from the NGO like the Valsad Raktadaan Kendra, Indian Red Cross Society, the community involvement and capacity building of the both government and NGO staff, and convergence with the other department like the tribal and other line department. Challenges are also there because these are the tribal groups, medically underserved. we have also some problem for in many tribal districts like Dahod or the Chota Udaipur, and most of the patients are from the lower socioeconomic class, and they are the poorly nourished and the low education level. So we have to take special care for them, and it is not a common priority program or national and state level. So we have to fight for every year, fight for the budget from the national NHM, and no specific cure at level. BMT is the costly and should have the different opinion. We have planned the Center of Excellence for the sickle cell anemia in the Surat, which will be functioning in next 1 to 2 years. Availability of the treatment in each tribal taluka for the sickle cell disease. One comprehensive sickle cell clinic in each tribal taluka. Research for the sickle cell anemia. Empower the tribal community or sickle cell trait and sickle cell disease to their own decision for the marriage and pregnancy. Still in this community in the India, decision of the marriage is not in the hand of the bride or the groom, and they integrate with the other concerned departments to get all the benefits for the sickle cell patients. These are some photographs for the activities in last year Azadi Ka Amrut Mahotsav. Thank you very much for giving me such opportunity. Over to Rahul sir.
Thanks a lot, Dr. Oman Misra. Yeah, Dr. Sasha, if you can continue, please.
So thank you so much for that, comprehensive overview of the sickle cell anemia control program in Gujarat. So there is lots to learn from the state of Gujarat about the activities which is being done at various levels, and how it has impacted patients' life is immense. Sir, probably there are a few questions in the chat from the audience. Should we take it right now, or we'll take once all the?
No, please right now, please.
Okay, sir. So there is a question from the audience that what is the current screening strategy for patients in sickle cell disease in the state? Probably you have already touched upon these points, but is there any new or innovative strategy which has been adopted in Gujarat which can be a best practice and adopted in other states?
No, we have stopped now the mass screening, but active screening and the passive screening is continue. Whoever the tribal person come to the hospital and having the symptoms of the sickle cell disease, or the medical officer or the doctor suspect that the patient may have the sickle cell from the family history. So he is screened for the sickle cell anemia. He is screened first by the sickling test or DTT test, and after confirmation is done by the HPLC.
Okay, sir. Thank you so much for that. I hope that has answered the question of the audience. And probably we can take one more question and we can go to the next point, and probably we can address some other points which can be a common discussion points among different states as well. Sir, considering the sickle cell patients have a very low health seeking behavior, which is a huge challenge, as you rightly mentioned. It is in a patient population who have a very low belong to lower socioeconomic status, and they do have challenges in terms of visiting the healthcare centers. So how in Gujarat you have taken initiatives to create awareness among general population, so that the gap between how we can address the various issues of sickle cell patients, including the stigma, which can be addressed at this point in time in Gujarat?
Yes, so this is the right question that I want to answer. Still today, sickle cell anemia problem has been conducted so far in India as medically only. Problem was treated as a medical problem only. We have take this problem as a health problem, as a social problem, as a social challenge. So and then only we can treat, and we can go up to the last man of the society. we can achieve in the TB, we can achieve in the malaria. Why? Because we can go up to the last person of the society, from the health side to the up to the doorstep of the patients. So in the sickle cell anemia, we have also implemented this program in our existing health system, and develop such a guideline that our health worker, our health counselor will go to the sickle cell patient, to the village person, and counsel them. And we have the counselor, and we have the counselor and worker them, that they are coming from their society. Some of them are also sickle cell trait and sickle cell disease. We took the help from our ministers, our political leaders, and some bureaucrats, which helped us very well. And some NGOs in this part also helped us, like the Valsad Ragdan Kendra, Siva Rural Jagadia, also helped us in the. But taking into the health and going up to the patient, we cannot solve the problem.
Thank you so much, sir. I think I hope that has answered the question of taking a comprehensive as well as a collaborative approach and addressing sickle cell disease not only as a medical issue but also a social issue can sort this out, and there has been an immense effort which has been done in Gujarat already. Thank you so much for that lucid talk, sir. Now I would like to invite Dr. Dinabandhu Sahu, who is the team leader of OSH SRC National Health Mission Odisha. Sir, the stage is yours. Thank you so much.
मेरा नाम भी राजवीर साहू है। मेरा नाम पुष्पित साहू है। मैं बड़े बाढ़ के मुंबई में काम करे बर जाना चाहता हूँ। डॉक्टर में इलाज करते का कारण मैं डॉक्टर बनना चाहता हूँ। डुबकना,
हेलो,
तैरना, खेलना भी अच्छा लगता है।
राहुल,
खेलना अच्छा लगता है।
Yeah.
can you stop this?
Yes. So maybe Dr. Sasank, since we are now moving to sir session, probably we can have this video played after this.
We can have the video. Yeah.
We can have this after this. Maybe, yeah.
So can you present the speech?
Yeah. Over to you,
Yes.
Sahu sir. Over to you.
Okay. Thank you, Novartis and the team. Good afternoon to all the respected speakers and Dr. Agrawal, who has given me the chance of presenting the state before the country. I welcome all the participants. This is the welcome from state of Odisha. As you know, the state of Odisha lies in the high prevalence incidence of sickle cell disease. This is the high prevalence zone of India, where constitutes of Jharkhand, Madhya Pradesh, Chhattisgarh, Maharashtra, and Gujarat. And today, already Jharkhand and Gujarat has presented. The frequency is so high; it ranges from 5 to 40%. And the state of Odisha fall in the high prevalence zone, that is for 21 to 40% of prevalence. Few castes in the state of Odisha, especially from western districts of Odisha, are more affected by this gene because of prevalence of endogamy marriage. So, as the incidence is more high in the Western Odisha, so the government of Odisha thought of to take a project in this 12 districts in the year of 2010. In 2 phases, we have started particularly from districts like Sambalpur, Sundargarh, Bargat and Koraput, like this, like 12 districts were taken into consideration, and the Center of Excellence was established at BSS Medical College, Burla, with headed by a professor and head of the department who was looking after. Particularly, the funding was from NHM. Then it was funded by the state budget. We are providing all the equipment, the instrument, the manpower, and provision. The only we are targeting the school going children, tribal schools, and there we are doing the screening and the provision of medicine and awareness among those people. So there is limitations like pocket of the population rather than the majority of where at risk were screened. No other clear strategy for or plan for specific steps for reducing burden of disease in the community. No specific initiative towards preventing stigmatization for diagnosis and attitude towards the carriers. No link with enhancing specific preventive and therapeutic service. As everyone knows, prevention of major hemoglobinopathies by Cyprus and Sardinia presents the best example in the country, world. So, basing on that, we had the new approach, the program beyond screening. That was mainly screening and treatment, but we are not targeting beyond screening. This was done in 2017 with the help of CMC Vellore and funded by DBT and Rural Electrification Division. It is a complete life cycle approach starting from the antenatal checkup. We start from the VHND session, village health and nutrition days, which occurs in our state in the Tuesday and Friday in the each community. And if the the pregnant woman gets positive, then the spouse is tested by HPLC, and if spouse both are positive, then we go for coronary village sampling testing, and if the fetus is positive, then we counsel for either for termination. Then we approach all the school-going students above the class 8, because after that they are most of the people of that tribal area and other in Odisha also they used to go to for marriage. So this is the life cycle approach what we are now doing. This is the MOU between CMC Vellore and Director of Blood Safety in presence of our Honorable Chief Minister in the December of 5th December 2017. So Government of Odisha looking the burden, and as the CMC Vellore has requested, the government was pleased to allow them to run this project in Odisha. So there are 18 and 19 was the preparatory period where they have prepared how to do. They have did the training of all the blood bank officers, all the medicine specialists of the state and pediatric specialists of the state. Then they developed the ICBC's activities, and all the preparatory work took about 1.5 years, and we have just started in between the pandemic corona affected our program, so we are delayed. So this is the methodology what we are following in our state, what is adopted, what is done by the CMC Vellore with the help of CMC Vellore. Because in the RI point, in the VHN session, the pregnant women are coming. We included all the ASHA. They have also been trained. The ANM has trained. Apart from the medical officers, our paramedics and the frontline workers all are trained by CMC Vellore. And the blood is actually collected in the routine immunization, which is all pregnant women, and if the spouse comes also for voluntarily, or if the female is positive, And from the RI point, the blood is sent to the nearest CSC where there is a cell counter. It should reach within the 15 hours of collection, or to the CSC where there is a cell counter if anybody comes walk in by active sample testing. So there we do we collect in a 200 to 250 microliter of blood by a micropipette, and it is transmitted to the CSC by a alternative vaccine delivery because it requires refrigeration and should be sent in the same day. So they have been provided with fund of rupees 200 to 600 depending upon the distance and the difficulties areas. So they bring the blood on the same day. So there at cell counter, there are LTs who are being given another extra remuneration than from our government, what is providing to them. So they did the solubility test and CBC where it is positive or it is doubtful, or then this blood sent to the HPLC center, which is our state in the SC Medical College, Kotak, established by the CMC Vellore, and if it is positive, then it is generated by SMS, a message go to that patient and to the ANM that this patient is positive, and then we just motivated the spouse for testing, and with this message the people become more aware, and there is a database. So next. So we have started not only in the 30 districts, we did it in a phased manner because we have to cover all the districts. So in the first phase, we took 6 districts, and in second phase, we took 9 districts, and in the third phase, we will cover all the 15 districts. By the end of this month, June, we are covering all the 15 districts, that is the first phase and second phase. And till now we have collected fully samples from the 11 districts, and the total number of samples collected till date is 38,500, and out of which samples screened 30,069. From total samples, antenatal samples number is 30,588, and the HPLC positive is 44,957. If you calculate, the prevalence rate is about 14%, 14 to 15%. The spouse, we have tested 481 samples, of which the positive is 102, and the incidence is about 21.2%. So if you will consider the HPLC positive, both antenatal and spouse, the incidence of sickle cell is 14.8%. So if you calculate the homo and hetero, out of the all positive cases, the sickle cell carriers are about 3,315, which is around 65% positive from the all carriers, and 99.7% from the tested all samples, and like that. The sickle cell disease is 98, which is about 1.8 positive, and that is 1.2 from the all the blood which is tested. Accordingly, we are also not doing for thalassemia and sickle cell anemia. We are also doing the same blood is coming for thalassemia, and of which 1,531 samples are thalassemia carrier, which constitutes about 30% positive and 4% from the total positive tested cases. Like this beta thalassemia and other disorder is about 2.2%. So simultaneously, we are also doing the cord blood sampling by the PCR method from the SC Medical College Kotak and VSS Medical College Burla. Till now, we have collected around 12,000 samples of cord blood from both SCB and VSS Medical College Burla, out of which there is positivity of 1,182, that is about 9.7%. So at present, the state is doing something that because it is managed by the state of Odisha, there is a separate director in our state who is looking after the blood and blood disorders. For treatment of these patients who have been identified, we have hydroxyurea present all over the state, being given by the state budget, and blood is supplied freely to all patients. Apart from that, the persons who are having sickle cell anemia or thalassemia, any major hemoglobinopathy, the state government is giving 500 rupees per month as a consultation or as a traveling fees. Whether they come or not come to the hospital or consult a doctor, their amount is being transmitted their account every month, 500 rupees. The blood and all the medicines like hydroxyurea, folic acids, all other vitamins are given in free of cost. Now the government of Odisha has decided that there are epidemiologists in all 30 districts who are a doctor, and they are mainly looking after the NCD program, diabetes, hypertension, and cancers, and the aged people. So these people will now be engaged to look after the diagnosed sickle cell patients, how to can take care of those patients, how to give advice, how to continue the medicine, how to look their benefits. So they have been given the extra charge, and we have trained almost all the doctors and the paramedics, even the AAA, ASHA, Anganwadi, and ANM. So as most of the prevalent district of Western Odisha are not till completed, because we will cover in the third phase all the other districts. Apart from that 15 districts we have covered, because Corona was a barrier to complete within the stipulated 5 years period. But by this end of this 2022, it should be finished. Because of 2 years for Corona affected, we could not go as we have proposed. So that's why CMC Vellore has requested government of Odisha to extend for another 2 years. So the government of Odisha is also agreed. So I think by 2023 we will cover all the 23 districts. So from the state of Odisha, the government is giving all the medicines, provision of amount 500 rupees is given. So I think the way we are going, definitely we will capture all the sickle cell anemia and thalassemia patients, and we can continue. And here there is a BMT center in state of Odisha at SC Medical College Kotak. Till now we have completed bone marrow transfusion. If some patients need, we can do. At present, the chorionic village sampling is done SC Medical College Kotak, Burla, VSS Medical College, and in AIMS Bhubaneswar. So there are 3 centers for chorionic village sampling, and about 11 doctors they have been trained. And we are recently going to establish another chorionic village sampling center at SML Medical College Koraput, so that it will be distributed throughout the state, and regionally there will be availability of doctors, availability of the laboratory, and the people need not to move from Western Odisha such a distance of 500-600 kilometers to Cuttack or Burla. So regionally, we are at present having 11 medical colleges. Those screened persons can easily avail. At present, the state is giving their transportation cost and also their hospitalization diet. We are giving according to distance, either 500 rupees or 1,000 or 2,000 along with one attendant. So this is the work being done with the help of CMC Vellore team now in Odisha, and we have kept an eye with all our nearby state who are doing, as Dr. Umang was telling, a great success story in his state, and Madam was talking from Jharkhand. We are having a good relation with all the states. I think with the help of all the dignitaries from the state, Odisha can do better. With that, I thank you and all the blessing from Lord Jagannath. Thank you.
Thank you so much, sir. Thank you so much for giving that comprehensive overview of Odisha sickle cell disease program and the various aspects what Odisha government is trying to address to better the patient's life with sickle cell disease. So probably before we go to the next question, I just want to kind of reiterate the same question of the audience. Is there any such awareness among general population which is planned, especially in Odisha, for improving the awareness of general population on sickle cell disease?
Yes, we have. We are doing very virulent ICBCC activities. We have taken the different heroes, film starting from film star up to the singers of our state, and they are giving their slogan, and we are passing it in electronic media, and we are every month we are giving in newspapers, highly circulated newspapers. We have done different ICBCC activity like putting on hoardings, giving leaflets, and we have done wall paintings, and the tin boards are there in all the government medical institutions. So we have used also the local language people for the Nukkad Nach, their Ghoda Nach, like all the things, the other local things we have used them. And we have hired a particularly agency who is doing from Delhi.
Wonderful, sir. I think that is something which we can also try to see if we can be adopted in the other states as well as a best practice. I hope that question is answered for the audience. So probably moving on to the next question, probably I will start with you and we can move next to Umang sir as well. There is a question from the audience on specifically on the disease-specific electronic medical record systems. Is there a role in terms of having a common disease-specific electronic medical record system in the state? And if it is there, how it can address multiple components such as patient identification, patient monitoring, navigation. Also, probably they have also asked a question on if the electronic medical record system has an advanced analytical capability, will it help in resource allocation as well for the government? Do you see the value in that?
Yes, it has a very great value, and though we have not done it completely, still then we have keeping all the data of the patient, those have been screened, and the result of what we are getting from HPLC, that is in database and particularly tagged with our maternal and child health tracking system. And I think we can have a relationship with you as you have visited, so that we can do this tracking process as you have proposed. And I think another meeting is going to be held few couple of days in this month. So we have a plan to propose it so that a database can be kept electronically, so that it will be better for review in future.
Thank you so much, sir. Thank you so much for those thoughts of yours on electronic medical record system. Umang sir, any thoughts from your end on what is there in Gujarat right now and what can be better?
As sir says, in Odisha, we have also integrated the sickle cell anemia registry in our MCDS also. No separate for the sickle cell anemia, but we have integrated all the programs in the our MCTS, and sickle cell also is there.
Okay, sir. Sir, does it help in more detail in terms of resource allocation or patient navigation and monitoring? Does it add value from the system that you're using right now?
Yeah, electronic system, MCTS always make a value for the research allocation. MCTS involves all the programs, and it also sickle cell disease is also one part of them, and sickle cell also affects the RCH program and the nutrition program. So it also helps. It helps for the allocation of the human resources, the drugs and the logistics and the treatment centers allocation. So we can have the center wise or the taluka wise the numbers of the patients and the caste wise patients, the sex wise patients. So we can have.
Wonderful, sir. So thank you so much for your thoughts. Sir, there is a follow-up question on the same. How can we interconnect all the hospitals in the states? Probably, I think what they mean is on the connecting all the systems like private, NGOs and the government hospitals. Is there a possibility, or how can we interconnect, and what is your thoughts on that?
At present, they are connected under the Ayushman Bharat.
Okay.
Under the Ayushman Bharat. And I think at present it is a big and it is the only platform, and we can connect them on the platform. Private, government aid, and the government, all the hospitals.
Okay, sir. Thank you so much, sir. Sahu, sir, any thought from your end on this, on connecting, interconnecting the hospitals?
As Dr. Umang told that, as you know, these patients are morely the poor people from the Western Odisha and from the tribal people. And all the facilities are available in the public health institution, which is run by the government of Odisha. And as we are paying 500 rupees every month, and that is going DBT by their account. So they have more faith in government sectors. And though in our state we are not accepting Ayushman Bharat, we are doing our Biju Swasthya Kalyan Yojana. There are also empaneled hospitals. If they are going there, we are also giving the same service as per requirement. But I think most of the people, they are preferring to come to the government sectors as the provision of all the things are in free of cost.
Thank you, sir. Thank you so much for your thoughts.
One more thing.
Yes, sir.
Ayushman Bharat has all the packages for the sickle cell anemia patients. I think all the packages for the treatment of the sickle cell anemia patient, I think bone marrow transplant is also there, as per my knowledge. जहाँ तक मुझे ध्यान है तहाँ तक. So Ayushman Bharat is a very good. Amount is very less, but package is there.
Okay, sir. Okay. Thank you so much for those thoughts, sir. So probably I think the next question I will be moving towards Dr. Anupa as well. Dr. Anupa, do you see any value in terms of having the point of care screening strategy at field level? So that is something, one more question which I think is not addressed from the discussion. So I thought I will just go to you before we move to Dr. Umang and Dr. Sahu.
Hi. Actually, I couldn't hear you because of the signal break. Can you please repeat the question? Yeah.
Yes, Dr. Anupa, there is a question from the audience on the utilization of point of care testing. So there's a question stating that, do you see solubility coupled with cloud-based point of care as a better screening strategy at field level?
Okay. In my view, actually, solubility test, if we do solubility test, we may miss many cases. So we always prefer HPLC for screening.
Okay,
no,
thank.
Can in our state we have not though we have purchased 6 machines and we have just started in one district. Point of care we under the help of ICMR which is situated in Bhubaneswar, we have got just blotting paper method point of care, and we have just started. The result will be just come soon because we have started in the 14th of this month in the state at district Jharkhand. And what CMC Vellore is now providing, will collect blood by blotting paper method, and with a machine called Malitov, who will do this test. So there won't be any harkat for collecting blood through this and transporting blood. So we can transport the blood by the paper collected, and it can be kept for months together. So there won't be
So
any
that would,
hurriness for transporting the samples.
so that would be,
So,
sir, that means that would be filter paper, right?
yes, madam.
Yeah.
Actually,
So,
actually, we have discussed this matter at the national level when we met for this guideline preparation in the Tribal Ministry Affairs Committee. So point of care test is now available, and it is better as HPLC is costly. Machine is very costly, and it is not possible at all the health center at taluka level or the PSC level. So we can have the point of care test at all the PSC up to PSC level, with which we can diagnose and screen the large scale population within a short time. Earlier, when we have started, such a facility was not available, and we have adopted the solubility test, but now point of care test is available, so it is a better choice. HPLC is a very good standard gold test, highest specificity test, but highly technical advanced machine is not possible at every taluka place.
Okay, sir. So just one question, probably to build on the point of care testing. Sir, do you see what would be the turnaround timing for HPLC results? Like, for example, I think the major challenge with SCD patients would be traveling from a distant place to the healthcare center. Do you see the point of care would add value so that there won't be the logistic issue of the patient? Then later the blood sample can be can be moved for HPLC for definitive diagnosis. There's something which which I wanted to ask from that point as
well. Definitely, the turnaround time for the point of care test can be laid down. We can bring down. In HPLC test also, we do not send the patient to the HPLC center. We collect the blood and send the blood in the cold chain to the nearest center, and we have almost all the HPLC center within the 150 or 200 kilometer area. So we can do that, but it is not possible in every part of the country. But now the point of care test is available, so it can be done, and turnaround time it can be reduced.
Thank you, sir. Thank you so much for your thoughts on the point of care. So the one more question which has been asked by the audience is on the expectations from different healthcare professionals for strengthening SCD. So what are your expectations on the clinicians, practicing clinicians at different levels, maybe at tertiary care centers, secondary care, and also from the primary care level? That's another question from the audience. So probably, sir, you can, Umang sir, if you can start, then I will move to Sao sir as well.
Can you repeat this? I can't get.
What are the expectations from your end on the healthcare professionals to strengthen the screening as well as the management of SCD at different levels?
Yes. So we have developed the guideline, our manual in such a manner that what is the treatment available and what is the treatment possible at the primary health center, what is the treatment possible at the community health center, and what is the treatment available or the when to transfer the patient at the tertiary care center. And we expect the patient at the primary health center. We do not have the physician at the primary health center. Anyone in the country do not have the physician at the primary health center. But we expect the medical officer at the primary health center at least identify the complication at earliest, like the pneumonia or the acute crisis, to identify it at earliest and transfer the patient to the nearest community health center or the tertiary care center, or the or to give the minimum treatment to him to save the life. And from the same thing at the community health center, and we expect the clinicians at the community health center, they can proceed something like a blood transfusion, and they can manage blood camp there, and increase the blood collection for the sickle cell disease patients, so minimize the mortality, and antenatal care they can manage at their level at the community health center, because every tribal cannot go up to the tertiary care center, which is almost 50 to 100 kilometers from the remotest area.
Yes, thank you so much for your thoughts. Sao sir, any point from your end on the same question?
Yes, as I have told in the beginning that the state goes beyond screening. That's why we started the training of the all medical officers, blood bank officers first, then all the pediatrician of the state and all the medicine specialists of the state. So we have trained all the doctors of these three category, and we have trained all the paramedics also, and all the AAA, ASHA, Anganwadi, and the ANM. So all the medical and paramedicals have been trained, and the availability of a drug. The objective is that once we screen the patient, we stamp that these patients are either carrier or disease. So they need how to be managed if they suffer from any sort of disease, or they need any sort of treatment at any time. That's why we have provided medicine in the all CHC and district headquarter hospitals. And in our state, there are a huge amount of blood banks and blood storage units, about 67 numbers of blood bank, and around 46 number of blood storage units. So, and as you know that the blood is being provided in free of cost along with all the medicines required for this. So as the doctors are trained, so they can give medicine, and as I have told that there are doctors in district headquarter hospitals who are looking after only the NCD and geriatric part. So they have been trained. So how to treat all these patients. Once these patients are stamped that in my district there are suppose 100 patients of sickle cell and 50 patients of thalassemia, so they will keep a track of those patients. They will counsel, and they will database when they need medicines. Suppose 1% is on hydroxyurea, how to follow up that patient, and where to cut off the medicine, then where to give the blood transfusion. All these things they will manage there at district level, and they have been specially trained. So I think with a comprehensive management system can be developed with the help of all these medical officers and paramedics, as we have trained them in the beginning of our program.
Thank you, sir. Thank you so much for those thoughts. And just one point, I think, let me just check if I've left any of the question. How can we optimize the use of HPLC and HB electrophoresis at different SCD prevalent regions? Probably this is one, as you rightly mentioned, sir, we do not have the availability of HPLC at all places. So how do we optimize its use is something which the audience has asked.
HP electrophoresis requires the highly skilled laboratory technicians and the highly skilled persons. And I think in this era and in this guideline of the HR management of the government, any government, any state government or the central government, no static laboratory technician, especially in the tribal area, are available for such a long time. So if we adopt the HP electrophoresis for primary health center. So we can have not a static laboratory, long time static laboratory technician at that area, and which will be not useful, and many undiagnosed or misdiagnosed patients can be there. So HB electrophoresis is not a good choice over the HPLC, as HPLC is a highly advanced and 100% highly accurate machine. The main cause is its cost. But nowadays, like Gujarat can afford HPLC at every district place, and we are planning that up to the end of this financial year or the next financial year, we can have the HPLC at all the district places.
So
Thank
one
you.
thing from me, can I say?
Yes, sir. Please, sir. Please go ahead.
Okay.
Sir, what Dr. Umang told is 100% correct, but you must be knowing that the Prime Minister has given all the facility of putting a free diagnosis in the state, and basing on that, there are all free diagnosis in all of the country we are providing to the all patients. So there is a hub and spoke model, and the blood can be collected from any places and from the spokes, and that can be given to the hub, and it can be done through the agency who is doing this HPLC test. There is no need of purchasing machine by the state or by the government of India. So in our state also we have planned to do in that way. So by the hub and spoke material, this can be even collected from this sub centers also, where there is a health and wellness center, where there is a CHO, community health officer. From there or from any place, blood can be collected, and that can be sent to the hub. So there we can get it. So this can be done. I think that will be more useful. Honestly, there won't be financial burden over the state.
Yes.
Thank you, sir. Thank you so much
Yes,
for
sir.
your thoughts. Dr. Anupa,
Sir,
you are,
Sir, as far as Jharkhand is concerned, the state government is buying HPLC instrument for all the districts. And that's why I was thinking, like, for our state, it may be feasible to collect blood and send to the districts and get HPLC done. I don't know, you are more experienced in this. So can you please comment about that?
Sorry, ma'am, pardon?
Our state government is providing HPLC instrument to all the districts.
Yes.
So I was telling that if we collect blood from the centers, PHCs, and send it to the district hospital for HPLC testing, will it be feasible? Like, is it possible, or do you think we have to go for certainly for solubility test?
Yes, we can collect the blood from the peripheral health center or the community health center and transfer it to the nearby district HPLC center and confirm it. But when you do at mass level, only HPLC is not a choice of test. When you do the passive screening, only the selected symptomatic patients. So HPLC can be done, but when you do the screening at the massive level, active screening, so it will be very costly.
Okay.
At that time, you can have the solubility test for the screening purpose. So you can screen the negative person. You can screen the negative from that population and identify the sickle positive, and then confirm the sickle cell trait or disease.
So in this program that where we are doing this DBT lead program, we have HPLC, and we are doing in that, but that's only in Ranchi district. So if we go for all the districts, maybe we'll have to shift to this point of care testing.
Yes. When you have to do only the passive test, you can adopt the HPLC test for the all. But you have, if you go for the mass screening or the major population screening, targeted screening. So you have to screen first negative persons and then do the HPLC for the confirmation for the positive DTT solubility positive only.
Okay, sir. In my experience, actually, we were initially doing only at RIMS, Rajendra Institute of Medical Sciences, and we were screening all the antenatal women with HPLC. After that, we started doing at Sadar, but once Sadar got its own HPLC instrument, they started doing with solubility test. So if solubility test is positive, they do this HPLC.
Yes.
Right. So the percentage, I haven't compared it statistically, but what I have seen, the amount of positive we used to get earlier is not the same as we get now. So I had a doubt about this, and then I was just thinking whether we might miss some of the cases of.
Ma'am, when we go for the targeted screening or the massive screening, we cannot afford the such a huge burden, huge cost in our country. When do the solubility test and do the HPLC for only the positive case? And as you said, you get the lower positivity rate, from that. But if we miss any solubility, if he miss any positive in the solubility test, he can. We had the 2% cross check, 2% cross check activity in the field level. We had adopted in that in the past, but we may have the positive persons either in the passive screening when they have the symptoms. In any way, they will come, compulsory come when they have the symptom. But cost will drastically come down.
Yeah. Thank you, sir.
Thank you so much, sir. Thank you, ma'am, for that question. And so there are a couple of more questions from the audience. Dr. Nilesh Jain has a question regarding the package for sickle cell disease management. So there is only the packages that the Ayushman Bharat covers is about rupees 1,500 per day in the scheme. So can you please guide on the package for sickle cell disease management is the question that is being asked.
Dr. Nilesh sir, that package is only for the medical management, and I told about the surgical management. There are the packages for the surgical management also. I have not the deep idea about the Ayushman Bharat packages, but when I was looking after the program, I had looked into this matter deeply. So I saw that there was a packages for the surgical procedures there. Yeah, you told that the 5,000 per day, that is only for the medical management, and that is right.
Thank you, sir. Thank you for that. I think there is also a follow-up question by Dr. Nilesh Jain on the package of red cell exchange procedure or any targeted therapy like crizanlizumab under Ayushman Bharat scheme. That is an.
Sir, it is not in my. I am not aware about the detail about the Ayushman Bharat packages, but you may have that available on the Ayushman Bharat website, sir. Detail packages.
Particularly in our state, there is no package for this because in government hospitals we provide it in free of cost, either the medicine or the blood or the surgical procedures. So if they are going from the beginning, I told that it is available in the free of cost in the government institution, why the people will go to the private institution. So all the patients are coming to the private from the private institution, the government institution, as in all the things are being provided in the free of cost.
Thank you, sir. Thank you so much for your thoughts. I hope Dr. Nilesh Jain's questions are answered. Now, Dr. Syed Asim has a question. Do you also screen for alpha thalassemia using DNA analysis? Anyone in the panel can take this question.
No, not through the DNA analysis, but we do the thalassemia screening with the help of the Indian Red Cross Society, and they have their guideline.
We are doing the thalassemia screening with this project. What we are going under CMC Vellore. Apart from sickle cell anemia, we are doing the thalassemia screening. I have given the number of cases. We have already till date. We have a number of cases of alpha thalassemia. That is beta thalassemia and other hemoglobin disease is about 113 cases we have till now. Out of the 34,000 patients are tested. So we are not only doing screening for sickle cell anemia, we are doing simultaneously for the thalassemia measures and other hemoglobin pathogens simultaneously.
In Jharkhand right now, we are not doing screening for alpha thalassemia.
Okay.
It's only for beta thalassemia and sickle cell anemia.
Okay. There's another question from Dr. Nasib Mumtaz about the nutrition program for sickle cell disease. Can you please elaborate on the guidelines on the nutritional modification in this regard, and what are those?
No specific nutritional modification guideline from health department. It is looked after by the WCD department, but we are giving the iron, folic acid for the daily supplementation, and after the blood investigation, if required, we give the another supplements also. And during the counseling, we encourage the patients for the protein supplements, high fiber, high carbohydrate diets. For that, that is no specific nutritional modification or the program posted. But we give the 500 rupees for every sickle cell disease patient per month from the Tribal Development Department, as sir says in the new Odisha.
So we have heard that actually we have heard that the government is going to supplement rice with iron. Are you aware of that? So there was a concern about beta thalassemia patients for this, because we don't want to give iron in their, like,
we have
integrated in their.
Still, we have not such idea that if we have, we will surely oppose that, or we will surely have the modification for our thalassemia patients.
Yes, yes.
Probably, I think, Sao sir, this question for both you and Dr. Umang on if you have a comprehensive hub and spoke model to manage thalassemia and sickle cell anemia, from transfusion to managing complication, transplants, all under one roof. This is a question from Dr. Ranjit.
Dr. Ranjit, our entire health system is a hub and spoke model, and we had a comprehensive referral community health centers and primary health centers and the tertiary care centers, which is just like a hub and spoke model. Patients are referred from the primary health center to the community health center, and from community health center to the district hospital or the medical colleges. But for the sickle cell anemia, we have the, as I've said in my presentation, we have the especially 4 comprehensive sickle cell care centers in South Gujarat, which have dedicated daycare center for the sickle cell patients, which manages the sickle cell complications there, and giving the blood transfusion and any other complication primarily. And if a major complication is there, they transfer the patient to the nearby medical college or the district hospital in the South Gujarat. And we planning to develop such a comprehensive sickle cell care clinic in and all the tribal talukas.
Thank you, sir. Dr. Sao, any thoughts from your end? From Odisha, is it the same hub and spoke model which is also being followed at Odisha?
Yes, we are also following the same model, and the patient screened depending upon their requirement. They either go to the CSC or district headquarter hospital or medical colleges. And particularly in tertiary centers, we are having the bone marrow transplantation facility and other things. But like medicines and blood transfusion can be given in district headquarter hospitals and the health CSCs.
Thank you, sir. Thank you so much for those thoughts. Probably this is, I think, almost all the questions has been comprehensively addressed. I don't think there's any room for the programs that is being happening at different state levels. Probably I'll request right now to play the videos that we have, and probably I think we can just come back to if there are any other questions to take.
हाय, मेरा नाम है लवली, मैं 20 साल की हूँ और मैं उड़ीसा से हूँ और मुझे सिकल सेल, हम 2 भाई 2 बहन हैं, तो भाई दोनों पॉजिटिव में अच्छे हैं और दोनों बहन को सिकल सेल ब्लड उसके अंदर 4 पॉइंट ही था, इसलिए दीदी गुजर गए। मुझे जब मालूम हुआ 12 थी मेरी उम्र, सिकल सेल हुआ है बोलकर सर।
How are you affected by sickle cell disease?
मैं बार बार बीमार हो जाती थी, बहुत बार मुझे हेल्थ इश्यूज होता था और पेन्स भी बहुत होते थे जब मेरा तबीयत खराब होता था। तो देखो, जब तो मेरे को स्टार्टिंग जब हुआ था तो बहुत तकलीफ होता था, पूरा जॉइंट्स पेन होता है, ये फुल पेन होता है। हेल्थ इशू होता है कि कहीं हम मर जाने वाले हैं। मेरे पास कुछ वर्क करने को मुझे मन ही नहीं होता था, सांस चढ़ जाती थी। तो ऑक्सीजन लंबा लेते हैं तो अभी तो भी जान जाएगी ऐसा टाइप लगता है फील। जब उठ के नहीं चल पाते, हम अपनी हालत में नहीं रहते, तो मम्मी ही वॉशरूम को लेके जाती थी मुझे उठा के।
Tell me about a sickle cell crisis.
जॉन्डिस स्टार्ट होने के बाद है ना, आंखें पीले हो गए और बुखार जल्दी आ जाता था, हेडेक फुल होता था। कुछ नहीं है बोलने के लिए, मतलब उतना ही हेल्थ इशू होता है। जब हम सोते हैं तो ऑक्सीजन लंबा लेते हैं, ब्लड इमीडिएटली कम हो जाता है। मतलब अभी वो भी बोलो क्या, लास्ट टाइम पे 4 पॉइंट हो गया था मेरा हेमोग्लोबिन। फॉरनली हॉस्पिटल पे आके जब मैं मरने वाली बची।
And what would you say the impact of sickle cell disease has been on you?
मैं बार बार बीमार पड़ जाती थी और मेरा तबीयत बहुत खराब हो जाता था। तो पापा है ना, जो मतलब उधार को भी लाके हमें ट्रीटमेंट किया है पापा ने। पापा के बिजनेस में तो सर मेरा जितना पहले तो नहीं मालूम था, तो पूरे बाहर ट्रीटमेंट करते थे तो पूरा अमाउंट खत्म हो गया। फिर पापा का शॉप भी बंद कर दिए, तो बहुत मैनेज कर देते थे, पर बहुत ज़्यादा हमने स्ट्रगल किया है सर। और मैं उम्मीद हार चुकी थी कि मैं नहीं जिंदा रहूंगी बोलकर, और उसके बाद मैं उम्मीद नहीं हारी और है ना जॉब पे स्टार्ट करी मैं जॉब जाना। जब मेरा हेल्थ थोड़ा अच्छा हुआ तो अभी मैं घर भी देख रही हूँ, घर भी मैं ही चलाती हूँ अब।
So you managed to turn it all around.
जब हेल्थ इशू आता है तो नहीं रहता है, ऐसे तबीयत में भी जाके मैं जॉब करके आती हूँ।
If you could say
छोटे बच्चे भी रहने दो, मेरी उम्र के भी रहने दो, मैं अभी जॉब भी करती हूँ। मेरा हेल्थ इतना इश्यूज था पर अभी कुछ भी नहीं है प्रॉब्लम। घर भी मैं चलाती हूँ, मॉम डैड भाई लोगों को देखती हूँ। ऐसा मत समझो कि हम सिकल सेल है कि हम कुछ भी हम कर लेंगे, आवारा फिरेंगे, ऐसा मत सोचो कि आप लोग ही बहुत टैलेंटेड रहते हो। सिकल सेल लोगों को ज़्यादा ही दिमाग रहता है, बहुत फर्स्ट रैंक में पास होते हैं। थैंक यू।
मेरा नाम भी राजवीर साहू है। मेरा नाम पुष्पित साहू है। मैं बड़े बाढ़ के मुंबई में काम करे बर जाना चाहता हूँ। डॉक्टर में इलाज करने का कारण मैं डॉक्टर बनना चाहता हूँ। डुबकना, तैरना, खेलना भी अच्छा लगता है। खेलना अच्छा लगता है। पीड़ा के कारण हम कभी कभी नहाए बर भी नहीं जा सका, तैर भी नहीं सका। स्कूल में पढ़ाई करे रहे और खेले ले और मस्ती मजाक करे में मजा आते। मोला मैथ्स और हिंदी अच्छा लगते। मोहला गणित और हिंदी अच्छा लगते। ये पीड़ा के कारण बहुत दुख होते कि हम स्कूल नहीं जा पाए। ये पीड़ा के कारण कई बार स्कूल नहीं जा सके। कभी कभी चक्कर भी आते, कभी उल्टी भी होते, कभी कभी पेट दर्द होते और कुछ भी प्रॉब्लम होते रहती। सिकलिन के बीमारी के सेती हमारा बहुत तकलीफ होते और होते कभी भी होते रहते। मतलब पेट में सबसे ज्यादा दर्द होते, मेरे को देता है सबसे ज्यादा मेरे को देता है यहाँ और यहाँ। मेरा यहाँ सिर होता है, दर्द होते मैं सो जाता हूँ। सिकलिंग के बीमारी के कारण हमें बहुत तकलीफ होती है। अगर हमारे मन जैसे कोई परेशानी हुई से तो ऊपर मन के दिल छोटा नहीं करना चाहिए। अगर ये बीमारी लाओ कोई हुई तो मतलब ये बीमारी से लड़ना चाहिए और अच्छा से खेलना चाहिए, अच्छा से खाना खाना चाहिए। अपन दिल छोटे नहीं करना चाहिए। ये बीमारी है कि सोचना नहीं चाहिए।
I'm Priyanka. I'm 23 years old. I'm live in Hyderabad, India. ఇండియాలో చాలా వరకు తెలీదు. కొన్ని ప్లేసెస్లోనే ఈ సికిల్ సెల్ అనేది తెలుసు కొంతమందికి. నాకు 2016లో డయాగ్నోస్ అయింది. అప్పుడు ఇది సికిల్ సెల్ అనేమియా అని చెప్పినప్పుడు అది ప్రొనౌన్స్ చేయడానికి కూడా రాలేదు నాకు. అసలు ఈ సికిల్ సెల్ అంటే ఏంటి, ఇది ఒక కొత్త వింతగా ఉంది, ఇది ఉంటుందా అసలు, ఇట్లాంటివన్నీ ఉంటాయా అని కూడా అప్పుడు కొంచెం తెలియకుండా ఉందన్నమాట. తెలియలేదు అసలు ఇది ఒక డిసీజ్ అని కూడా తెలియదు.
How painful is sickle cell disease?
ఇంకా చిన్న ఇట్లా కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వస్తుంది. పెయిన్స్ వచ్చినప్పుడు అంటే హ్యాండ్ కూడా కదపడానికి రాదు. హ్యాండ్ పెయిన్ వచ్చినప్పుడు లేవడానికి రాదు, నడవలేము, ఏమీ పట్టుకోవడానికి రాదు. ఆ పెయిన్ వచ్చే టైంలో ఎక్కువ పెయిన్ వస్తున్నప్పుడు బ్రీత్ కూడా చాలా కష్టంగా ఉంటుంది. ఇట్లా కదపడానికి కానీ అసలు కొంచెం ఇట్లా ఎవరైనా బెడ్ దగ్గరికి వచ్చి బెడ్ కొంచెం టచ్ అయినా కూడా చాలా పెయిన్ వచ్చేది. అసలు తట్టుకోలేనంత నొప్పి వచ్చేది. ఈ పెయిన్ ఉన్నప్పుడు ఎప్పుడు చేసే పనులు కూడా చేయలేము, డైలీ చేసుకునే పనులు.
So, are you working at the moment?
3 months నుంచి నేను పెయిన్స్తో ఉండడం వల్ల వర్క్ చేయలేకపోతున్నా. దానివల్ల శాలరీ లేదు. ఇప్పుడు అట్లా శాలరీ అమౌంట్ లేకుండా ఉండడం వల్ల ఇప్పుడు బయటకి ఎక్కడికైనా వెళ్ళాలనుకున్నా ఫైనాన్షియల్గా ఈ ప్రాబ్లం ఉండడం వల్ల వెళ్ళలేము. ఒకవేళ ఏమైనా తినాలనిపించి కొనుక్కోవడానికి కూడా కష్టంగా ఉంటుంది. ఏమన్నా చెయ్యాలి అనుకున్నా అది చేయలేము, అంటే ఫైనాన్షియల్గా అంటే డిపెండ్ అవ్వాలి, వేరే వాళ్ళపైన డిపెండ్ అయ్యి చేసుకోవాలి. మనం సొంతంగా చేసుకునే పని కూడా చేసుకోలేము.
Are you married? Do you have a family?
ఎక్కువ మంది అంటే పెళ్ళి చేసుకోకుండా ఉంటారు. కొంతమంది పెళ్ళి చేసుకున్న వాళ్ళు కూడా ఉన్నారు, మంచిగా ఉన్నారు, వాళ్ళు యాక్సెప్ట్ చేస్తే. కొన్ని అంటే కొంచెం డెవలప్డ్ ఏరియాస్ ఉంటాయి కదా, వాటిలో కొంతమందికి తెలుసు. చాలా అంటే విలేజెస్లో అయితే చాలా వరకు తెలీదు. ఈ డిసీజ్ గురించి చెప్తే అలాంటి డిసీజ్ కూడా ఉంటుందా, అలాంటిది ఎందుకు వస్తుంది, అట్లా అంటే తెలీదు చాలా వరకు. చేసుకున్న వాళ్ళు అర్థం చేసుకుంటే ఏం కాదు. ఒకవేళ అర్థం చేసుకోకపోతే ఈ హెల్త్ ప్రాబ్లం ఉన్నందుకు వాళ్ళు యాక్సెప్ట్ చేయకపోతే చాలా ఇబ్బంది అవుతుంది. ఇంకా వాళ్ళు మనల్ని వదిలేస్తే మళ్ళీ ఇట్లా ప్రాబ్లమ్స్ అవుతూ ఉంటాయి.
So you don't want to get married because of sickle cell disease?
ఇంకా మళ్ళీ ఇప్పుడు ఉన్న ప్రాబ్లం కాకుండా అవి ఇంకా డబల్ వేరే ప్రాబ్లమ్స్ అవుతాయి. అవన్నీ వద్దు అనుకొని ఇంకా ఇట్లా హ్యాపీగా, ఇట్లా హెల్తీగా ఉండి ఇట్లా హ్యాపీగా ఉంటేనే మంచిది అని అనుకుంటున్నాను.
How has this disease affected you?
ఒకవేళ నాకు సికిల్ సెల్ ఈ డిసీజ్ లేకపోయి ఉంటే నేను మంచిగా చదువుకొని నేను డాక్టర్ అవుతుండే. చిన్నప్పటి నుంచి డాక్టర్ అవ్వాలని నాకు ఇష్టం. ఈ సికిల్ సెల్ వల్ల ఊరికే హాస్పిటలైజ్ అవుతున్నా. దానివల్ల ఫైనాన్షియల్గా ఇప్పుడు చదువుకోవడానికి ఇంకా మళ్ళీ హెల్త్కి బ్యాక్గ్రౌండ్ సపోర్ట్ లేదు.
Priyanka, if you could tell all the world one thing about sickle cell disease, what would you want to tell them?
సికిల్ సెల్ గురించి అవేర్నెస్ చేయాలి. అది రాకుండా ఉండడానికి, అది ప్రివెంట్ చేయడానికి జాగ్రత్తలు తీసుకోవాలి, ప్రికాషన్స్ తీసుకోవాలి. ఈ సికిల్ సెల్ ఉంది అని ఎక్కువ బాధపడేది కంటే తొందరగా తెలుసుకొని దానికి మంచిగా మెయింటైన్ చేసుకుంటూ మంచిగా హెల్తీగా ఉంటూ మంచిగా మెయింటైన్ చేయొచ్చు. అంటే ఇప్పుడు ఈ సికిల్ సెల్ ఉంది అని ఇట్లా నాకు తెలిసినప్పుడు వాళ్ళకి నేను చెప్తే అంటే ఇట్లా అని జాలి చూపించేవాళ్ళు, ఇట్లా అంటరానితనంగా ఏం చూడలేదు.
Thank you so much for sharing that video. And now I would like to thank Dr. Umang sir in detail, and also on the work which is being done by government of Odisha, government of Gujarat, as well as Jharkhand, to strengthen the SCD care, as well as the support the government is giving for the voice of the patients in sickle cell disease. Thank you so much, sir, once again for being a part of this discussion and addressing all the queries of the audience up till now. Now there's a last question in the section. Probably I would like to request any of the clinicians. Dr. Rita Saxena is here, and the question is from Dr. Kalpita on: have you utilized more compression therapy in low grade AVN? If yes, how is the prognosis? Please share. If anyone can take this question.
Dr. Shashank, your voice was not very clear. Can I request this repeat one? Hello? So I think maybe there is some network issue at Dr. Shashank's level. I can see Dr. Anil Khatri sir and many other eminent faculties on the screen. So welcome all of you. So I think there was one question which Dr. Shashank was also trying to ask, that how do we manage the avian hip patients, including pediatric and adult? So I think may I request any of the esteemed faculties to answer that or take that? Maybe Dr. Sahu sir or Anil Khatri sir.
Actually, I could not listen the question properly. Can you repeat it once again?
Yeah. So the question was, I mean, how do you manage the avian hip patients, including pediatric and adult, and how many have gone under surgical process?
Exactly, I don't have that data because now we are only restricted for screening and identification of the patients, and those are particularly from Western Odisha. That data may be there in the Center of Excellency. That data we have not collected, but definitely we are managing those cases because that program is running since 2010 in the Western Odisha, and much more patients are coming from that 12 districts. We are managing that, but I don't have the exact idea what we are managing over there. But all the provision of medicine, surgical procedure are free of cost as per our state mandate.
Thank you so much, sir, for your thoughts. Can I ask if Priyanka ma'am or Rita ma'am, any of you have any experience with the utilization of bore compression therapy? Bharat Parmar sir. Hello. So probably I think we can take this question on a later time point. Rahul, you're on mute.
Yes, Dr. Shashank.
So Rita ma'am, are you there on the call? You're on mute.
I think there might be some network issue, Dr. Shashank.
Yes. So probably I think we can take this question in a later time point. Now, I would like to thank all the experts who has been a part of this entire panel discussion as well, and providing your valuable thoughts and inputs on various aspects of government programs and strengthening the sickle cell disease care in the country. Thank you so much. And Rahul, I'll hand it over to you, the next part of the program.
Yes, Dr. Shashank. So I also like to thank all of you for your esteemed presence as well as active contributions and insights. We begin the next program in another 5 minutes time, wherein Dr. MBS sir will be coming, and we are also having a international speaker, and of course all the power-packed agenda with all the esteemed faculties over there. So I also take this opportunity, to say that with all insights and guidance received from all of you, I think we also understand the importance of VOC monitoring, and perhaps that is one of the reasons, based on the feedback as well as suggestions from all of you, we have also created a VOC diary for all the patients. Now, these VOC diaries are in multiple languages, wherein a patient himself or herself monitor the symptoms on a periodic basis. We got to know that not all VOCs are monitored by the patient, and most of the VOCs, patient manage at their own level. So understanding the fact that each VOC matters and every VOC may lead to probable future complications of end organ damage, we thought of creating a VOC diary, which is there in regional languages. Also, we have created an app, and based on that app, I think patients can also digitally monitor their VOC. Along with VOC monitoring, it also tells us other informations about the various altitudes which a patient was exposed. There are so many other informations. How severe was the VOC? There are different ratings that a patient need to give. Was there a hospitalization required during that VOC? So there are multiple other contents which can be captured into that. So I thought I'll take the opportunity, to again thank all of you for the feedback, because based on such feedbacks, we continue to support and help patients of sickle cell disease. So maybe now I just check with Kalpesh if we have Dr. Agarwal sir.
my great pleasure to introduce this evening's symposium on sickle cell disease to you. It's a joint venture between Mumbai Hematology Group and Novartis, and I thank Novartis for supporting our academic activity. We have 4 lectures in the first half of this, followed by a panel discussion. Our first speaker this evening is Professor Maitri Bhattacharya. She is Director, Institute of Hematology and Transfusion Medicine at the Medical College, Kolkata. She also Honorary Secretary of Indian Society of Hematology and Blood Transfusion. She's going to speak to us on newer strategy to improve point of care diagnosis. Over to Professor Maitri.
Thank you, sir, for kind introduction. Good evening to all of you. So my talk today is on point of care diagnosis of sickle cell anemia. So sickle cell anemia, as we all know, is a disease which is prevalent more in Maharashtra, Gujarat, and all these areas. So I think it's less in West Bengal, but as such in India, this prevalence is very high, and it needs a, I don't know, it's not getting shared. Hello?
Yes, ma'am. You just click on your. You just click on your presentation.
Yeah, I'm thinking, but it's not getting shared.
Yes, make it full screen, ma'am. Yeah, please go ahead.
Okay, so we need to have diagnosed the patients at the early stage for proper treatment of sickle cell disease. I'll come to that, why we need to diagnose the patient at the earliest stage. So at the present situation, what happens, like if the patient has anemia, patient suffer from some sorts of pain which the physician thinks that this may be a sickle cell crisis, then patient goes to the local hospital, patient will be referred to a district hospital. Most of the district hospital doesn't have the facility to diagnose sickle cell anemia, so the patient will be finally referred to the medical college for diagnosis, and after that patient will come back to the village again. So this takes a long time, and this is not suitable for diagnosis of sickle cell anemia at the early stage. So in the Indian scenario, what there is a report by ICMR, what they have reported that 20% children die before the age of 2. So we need to diagnose before the age of 2 and start treatment before the age of 2. 30% of the children in the tribal community, they don't reach the adulthood also. So if we want to improve all this, we need to diagnose them by a neonatal screening at the time of birth only. And we'll have to educate the family, start the prophylaxis for infection. Most of the days in the infancy is because of infection, and treatment with transfusion and hydroxyurea. So this is what you can see, that the way the newborn screening is done in India, and you can see this is in different states of India, but it's in by HPLC only in most of the states. And all of you know that HPLC is one instrument that cannot be used in the field. It's to be in a specialized laboratory. So what are the traditional testing methods for sickle cell? All of us know from our MBBS days about sickle cell solubility test. Nowadays kits are available, so you can put the blood with the solution provided in the kit, and you can see, if you can see that if you can read the line behind, then this is a negative. If you cannot read, that is positive for sickle cell. But this is not specific for sickle cell, and you cannot diagnose whether it's a trait or a homozygous sickle cell disease. So a confirmation is required. Hemoglobin electrophoresis, what was the most common method even 10-15 years back. So this is good. This can diagnose sickle, but problem is that it's time consuming, it's laborious, it needs a very expertise, it's a very fine test, and this cannot differentiate hemoglobin S, D, and G. These comes at the same place in the electrophoresis. For HPLC, this is the confirmatory test, but this is again labor intensive, and but this is reliable. This is expensive also, and you can test at the same time 80 to 90 sample by HPLC. Isoelectric focusing, this is very suitable for neonatal, because you will take a very small amount of blood, but this is a bit complicated because this assesses all the hemoglobin. Hemoglobin A is divided into A1, A2 like this. So there are problems, but you can detect C, E, O separately, and S different from D and G, what we get in electrophoresis together. So that's an advantage, but this also requires a special skill for diagnosis. So for the traditional testing method, you can see that all the methods, whether it is isoelectric focusing, HPLC, these are reliable. They can distinguish between other types of hemoglobinopathy and sickle cell disease, but most of them are expensive. They require skill and not suitable for use in the field. So why we need a point of care testing? What WHO estimates that if you can diagnose the patient early and intervene early at the by a neonatal screening and diagnosis, so it would be possible to prevent death in 70% cases what we are facing now. So, but what is the problem for newborn screening is that the tests what are available are costly. These are not available in all the places, like not in a district hospital, not in a primary health center, not in a subdivisional hospital, and the fund is not available. It's not a sustained availability of fund. So the standard clinical laboratory methods, other problems is that it requires at least minimum 1 ml of blood. It requires uninterrupted electrical supply, which may not be available in a village. The dedicated person who is trained to do the test is required, and that blood sample needs to be tested to the lab for testing, and again the report to be sent back to the village for the information of the parents and for counseling. So this takes a long time also. So the point of care screening of sickle cell disease, what are the tests we have for point of care testing? This is one study where they reported this is a kit which is available. This is mainly suitable for African population because it can screen ACE and C also. So you can see that heel prick blood is enough. So this is taken in the strip and this is put into the solution. After that, this the blood get dissolved into the solution. Then another test strip is there, is put into the solution, and this will give you the band. So whether depending on the band, whether it's A, C or S, you can diagnose whether it's sickle or sickle SC, like that. So the specificity and sensitivity of this SC type of detection, you can see the even the positive predictive value, negative predictive value, these are pretty good, like 98 to 90% also, sometimes it's 100% also. So these are the tests which have very good sensitivity and specificity. This was a multi-centric study that was done with this kit. Other test which is available for a field diagnosis or point of care testing is a microfluidic paper-based test. Here, it's a blood is given in the fluid. This fluid actually contains saponin and sodium hydrosulfide. So this lyes the blood and hemoglobin. If it's sickle hemoglobin, it gets sickled, and then it's put on the paper. This is a cellulose acetate paper. So once the hemoglobin is sickled, so this cannot travel more. It gets concentrated in the central area. So you can see if it's a normal one, this left hand side is a normal one. You can see this is a homogeneous distribution. If it's A and A, some hemoglobin has got to the outside, but mostly it's concentrated in the center part. If it's ACS or homozygous sickle, this will be in the center part only. It's very easy test, can be done by a peripheral field worker also if he or she is trained into this. Another method is density-based test or acute multi-phase system. These density-based tests, this actually because RBC density differs whether it's a sickle hemoglobin. So if you give the blood into this column, this is a small capillary tube which is filled with amps, and if you give it into the blood, this will differentiate according to the density of the RBC. You can see if sickle negative test, these are clear areas, but these are the hazy areas with blood if it's a sickle positive test. But the problem is that this requires a centrifuge blood to be given. So only RBCs is to be given into the capillary, not the whole blood. But they have also they have also came out with some small centrifuge machine which can be operated by a battery only in the field. So by that way, we can use this density-based test also in the field. There is another method which has come on. This is lateral flow immunoassay. In this lateral flow immunoassay, blood is given into the test kit. This is a sample, blood sample site where you should put the blood. Then there are antibody conjugated with colored nanoparticles. So blood will combine with that, and after that, this will be detected at different line according to the hemoglobin type of the blood. So you will get more than one line, whatever according to the type of hemoglobin present in the blood. So this is actually that's what I showed is the basic principle of the test, and what we will get in the test is this type of line, whether it's A, S or C. So by this is the site where blood is given. You can't see the nanoparticle and conjugate from outside, but you can see the final lines by which you can diagnose that whether this is a sickle cell carrier or sickle cell, or it's a SC disease also. But it doesn't require any centrifugation as it was required on the density based test. So it can be done easily in the peripheral time, and it gives more than one hemoglobin. So if it's AS, you know that it's a carrier. If it's only S, you know that it's a homozygous sickle cell. That is another advantage of this point of care testing. Heme chip or micro electrophoresis assay. This is basically a electrophoresis which is in a very small form. In a short strip, you can do the electrophoresis. What way we normally do the electrophoresis, as I have shown you. So this is small version of hemoglobin electrophoresis only. So very small amount of blood is required for this test. This blood is placed on a cellulose paper, that the same way an alkaline buffer. It's the same way as we do electrophoresis normally in a conventional method. The paper is then inserted into a device which is electrically charged, and there are chips for cellulose assisted electrophoresis. After that, the bands will get separated. So you will get this type of bands, and you can quantify also using this method. So this is a validated method for, and this method has been validated with HPLC also. And this can differentiate between S, C, A, D, and F. So this is a very good method. This is a very short form, miniature form of electrophoresis, which can be used in the field, and you'll get an instant report for diagnosis of sickle cell disease. This is another equipment which has been used in India, that is Gazelle. That is a microchip based instrument, which you can say that this is some sort of instrument like HPLC. What we are doing the test in the laboratory, this can be done in the periphery only, in the field. So by this assay, they have shown that for sickle, the accuracy is 100%. You won't be able to diagnose beta thalassemia or others, but you will be able to diagnose HBE trait, SC disease, SC also. So this can be used for diagnosis of sickle cell trait and sickle cell disease in the field, and this is very effective also and very efficient also. So if we can see the pros and cons of the point of care testing methods. So one is AMS, which is density based. This is inexpensive, and all the methods, the paper-based sickle cell, what I showed you, like the dot in the center, that is also inexpensive. Sickle scan or lateral immunoassay, this is also reliably identifies A, S, and C. And heme chip, very good and reliably identify all these. First two are inexpensive. Second two are not that inexpensive. The sickle cell or immunoassay, this is expensive compared to the other test. And this one, heme chip, also is not that cheap when it's compared with AMPS and paper-based sickle test. But for AMPS, I've shown you the microcapillary tube. This is interpretation is not very easy. It's not a clear-cut thing what you are seeing at the bottom of the tube. So interpretation is difficult. So and the reliability is less. So this is not a very good method for screening the sickle cell patient or even screening in the peripheral plane. Paper-based method, it requires a scanner for final result, though it's inexpensive, and any person can use this, even by non-skilled person, because the dot and other surrounding area can be read by any person who is not a professional expertise also. Sickle scan is expensive, but this is reliable one, and heme chip is the best one, I think, out of all these POC methods which are available for diagnosis of sickle cell disease. So not only for diagnosis of sickle cell disease, now there are devices which will help you to monitor the sickle cell disease patients also. So I'll show you a few. like this is one instrument which is designed like that. This part is endothelialized, like endothelial cells, like normally in a blood vessels, and you can assay the when you have given the blood of a sickle cell patient, you can assay the adhesiveness of the blood when the blood is forming an aggregate. So depending on the changes of the RBC, by this way, if you have done the test at the baseline when you have diagnosed the patient, and after that, suppose you have started therapy with hydroxyurea, you can repeat the test and you can assess whether your hydroxyurea therapy has become effective, whether there is any change in the RBC endothelial interaction. So this is a very good, this is a field test also, by which a peripheral, in the peripheral field, non-hematologist, non-expert person, they can assay whether the person's RBC changes are less with therapy. This is another microfluidic platform which actually assesses the rheology of sickle cell disease. This also can be used in the peripheral system, in the periphery, for assessing whether your therapy is effective and what is the condition of the RBCs of the patient. So this can be assessed, and further whatever intervention is required, that can be taken according to the result of this test. Now, last one is a sickle cell test biochip that provides a rapid and fully enclosed standardized system which analyze mainly RBC adhesion in whole blood sickle cell patient. So that also again gives you an idea whether the RBC has been modified by your therapy, whether there is any chance of VOC or not. So not only we have devices for field diagnosis, we have devices for diagnosing exact like what is happening in vivo in the patient with the RBCs, and after therapy whether you are able to, whether we have become able to modify those RBC changes also. So both diagnosis and monitoring the sickle cell patient in the field can be done by point of care testing. I hope that in future all these will be available in India also for providing proper care. So to sum up, sickle cell disease, as I have already told you, it requires early diagnosis and constant monitoring. So both the things are required. Not only diagnosis will help you, monitoring also is very important. So whatever we have seen that conventional screening and monitoring tools are not feasible for operation at the point of care. So you need a specialized lab for diagnosis. And for that, there is economical burden also. The patient will have to travel to the hospital. They will have to get the test done in the hospital, which is more costly, and patient will have to go back to the village. This affects the patient's quality of life also. If you can diagnose and treat the patient at the same level where the patient resides, the quality of life will be much better. And I think by that also patient will adhere to the therapy more, rather than if the patient needs to come to the central area for diagnosis and treatment. And the newer POC technologies, these are what I've shown you. These are cost efficient, rapid, and reliable screening method of sickle cell disease. And I think if these are available, then only we can go for a universal screening, a neonatal screening, especially in a developing country. Like we can screen specific babies which are born in a district hospital, in a medical college. We can start screening any moment. But if we want to go for a universal screening all over India, then of course we need this type of point of care devices for a universal screening, which will be helpful in the field and which will be inexpensive, and which at the same time it should be reliable also. So, and not only this diagnosis also, as I've shown you, there are other microfluidic platforms which are actually mimicking the biophysical condition of the sickle microvasculature. So it mimics the in vivo situation or biomicrovascular situation of a sickle cell disease patient, and that will give you an idea what is the in vivo condition of the patient and whether your therapy is effective and whether patient is going to have more VOCs or not. That will help you to monitor the patient also. So with this point of care devices, I think in future we'll be able to diagnose the sickle cell patient at their doorstep, and we'll be able to give them therapy and monitor also properly. And that only if these are effective and if these we can implement properly, then only it's possible to reduce the mortality and morbidity of the sickle cell disease patients. Thank you.
Thank you, Professor Maitri. That was a wonderful journey about improvement of point of care diagnosis of sickle cell disease and its application to India. We have a couple of minutes if any one of the faculty member present here want to ask some question to Professor Maitri. Also request the audience to put in the question in the question box or the chat box. Okay, so if there are no questions, thank you so much, Professor Maitri. We'll move on to the second speaker this evening, and that's Professor Priyanka Samal. Dr. Priyanka Samal is Professor and Head, Department of Clinical Hematology, Hemato-Oncology and Stem Cell Transplantation at IMS and SUM Hospital, Bhubaneswar. She's going to be speaking to us on improved sickle cell disease outcomes, monitoring beyond hospitalization. Over to Dr. Priyanka.
Thank you, Agarwal sir. Thank you, Novartis. Just I'm able to share the slides from my end.
Dr. Priyanka, is your presentation there with Kalpesh?
Yes, sir. Sir, am I audible?
You're audible. We can see you, we can hear you, only we can't see your screen.
Just a minute, sir. I'll try it again.
Take your time.
No, sir. You can ask Kalpesh to save the slides. I had made some changes, but still, sir, we'll go along.
Fair enough. Kalpesh, can you share the screen?
Sir, I don't have a slide, sir.
You don't have the slides. Can we do one thing? Can we have Dr. Siddharth Shankar Ray have his presentation?
Yeah, sir, sure. I will share my slides and then we can have.
We'll do that. So it's my pleasure to introduce our next speaker, Dr. Siddharth Shankar Ray. He is MD, DNB, DM Clinical Hematology. He's Professor, Institute of Hematology and Transfusion Medicine, Medical College, Kolkata. And Dr. Ray is going to speak to us on optimized use of hydroxyurea in managing sickle cell disease. So over to you, Dr. Ray.
Thank you, sir. Thank you. Thanks a lot for giving me this opportunity. So I will share my screen now. Is my screen visible?
Yes.
Click on play, sir.
Perfect.
Okay.
Perfect.
Okay. Good evening, everybody. So now I am going to discuss the optimized use of hydroxyurea in the management of the sickle cell disease. So Hydroxyurea, as we know, it inhibits cell division by inhibiting ribonucleotide reductase enzymes and inhibiting the DNA synthesis. Hydroxyurea was first approved by the US FDA in 1967 as an antineoplastic drug. And in 1984, induction of the hemoglobin by the hydroxyurea was documented first time in 2 adults with sickle cell disease, and the benefit of the hydroxyurea is also seen. Thereafter, several studies documented that the hydroxyurea is beneficial for the sickle cell disease treatment, and as a result, in 1998, US FDA approved for the sickle cell disease use of hydroxyurea. So, but the hydroxyurea does not only decrease the DNA synthesis and act like that in case of sickle cell disease. Their main mechanism is hydroxyurea in sickle cell disease patient increase the hemoglobin F production. It causes shift in the gene expression at the beta globin locus and ultimately resulting that increased expression of the gamma globin locus, and this will result in increase in the hemoglobin F and relative decrease in the hemoglobin S, leading to less polymerization and less sickling. In addition to that, hydroxyurea increase the nitric oxide level by decreasing the hemolysis, so decreasing the scavenging of the endogenous nitric oxide, and as well as it increases the nitric oxide production. Hydroxyurea also alter the RBC rheology in such a way it shift the RBCs towards more mature RBC. As a result, increase in the RBC volume, density, in adhesivity, and resulting in smooth passage through the microcirculation and less vasoocclusion. Hydroxyurea also causes reduction in the WBC and platelet count, and reduced WBC count and the reduction in the neutrophil adhesivity in the vascularity result in the ultimately decrease in the vasoocclusion. Now, what are the evidence that hydroxyurea benefits sickle cell disease? There are plenty of studies from different times in India and abroad which showed that it is beneficial. I will go quickly through that. First study, that is the multi-site hydroxyurea study. 300 patients were there as adult sickle cell disease, and it concluded that if you use hydroxyurea in adult, it reduces the VOC event and increases the hemoglobin F level and MCV. But then the question comes, whether can we use hydroxyurea in the children? Hug Kit study, they uses hydroxyurea in children of 5 to 15 years of age, and then they concluded that hydroxyurea is safe in sickle cell disease children and also beneficial also. Then the question came, how young age we can give, whether we can give hydroxyurea in the infant. So there are 2 studies. One is baby hug study, which shows it can be used with beneficial effect, and HUSAP study. Both these studies, they conclude that the hydroxyurea can be safely used in infant and associated with beneficial effect in the hematological parameters, and was retained for longer period of time. Now, there are 2 large studies. One is NOHAM study, more than 200 children, and REACH study, almost 650 children were included. And both these studies also documented the similar, that there are benefits in the hematological parameter with associated improvement in the acute sickle cell disease related event like decrease in the VOC, decrease in the transfusion requirement, decrease in the acute chest syndrome, and reduced mortality also. Now, different Indian study also showed the similar result. Like this study of 77 patients, including adult and children also from Maharashtra and MP, they showed that it is beneficial. This is another study from the Maharashtra, but here it is in the done in the children, and it shows that hydroxyurea in children showed a significant benefit in hematological parameters and associated improvement in the acute sickle cell disease related events. There are a few studies from the Odisha. This study 142 patients, there are 140 patients from the Odisha again. This is 100 patients from the Odisha. All of these studies, they showed that hydroxyurea uses significant benefit in hematological parameters with associated improvement in the acute sickle cell disease related event. Now, this is another study from the Gujarat in children, and this is a study from the Chhattisgarh. This is also Odisha. This is actually a study in the sickle beta thalassemia, special type of sickle patient, that is sickle beta thalassemia. There also they have found that if we use hydroxyurea, it is beneficial. It is improved the hematological parameter and associated with decrease in the acute SCD related events. Now, this is another study from Chhattisgarh in the children. It also shows similar results. So we can see hydroxyurea is beneficial. Now, does decrease the mortality? So all those studies in the abroad, they they address that aspect also. But in our India study, we have not found any study which correlate the use of the hydroxyurea with decrease in mortality. Anyway, from the study which was done abroad, it showed that hydroxyurea taking was associated with up to 40% reduction in the mortality, and individuals who had higher hemoglobin F level at the beginning usually have less mortality, and individuals who had acute chest syndrome history or who had 3 or more painful episodes have a higher mortality. So from the different studies, we have seen different countries formulate their guidelines for treatment of the sickle cell disease, and they include hydroxyurea in that treatment guidelines. Like this is the BSH guidelines, British guidelines, this is the American guidelines, and this is our Indian guidelines, NIH, ICMR, and National Health Mission guidelines. All of them address that we have to include hydroxyurea. So if we want to summarize these things, we can say that, okay, that, excuse me, that studies conducted in India and West have found the significant benefit of hydroxyurea in reducing the VOC, acute chest syndrome, and reducing the blood transfusion requirement, and also improvement in the hematological parameter. So hydroxyurea should be initiated as early as 9 months of age, and hydroxyurea should be offered to patients if VOC impair their daily activities, and hydroxyurea should be offered to all patients diagnosed irrespective of the genotype in view of the reduction in mortality. So what is the optimal dose you should use? Outside study, they used maximum times that 15 to 20 milligram in adult, 15 milligram, 20 milligram in children. But most of the Indian study, they use 10 to 15 milligram. And even the guidelines also, the British and the American guidelines, they are suggesting 15 milligram per day for the adult and children 20. But our guidelines suggest that we can start with 10 to 15 milligram per kg, and then we can gradually increase. So to summarize, that studies conducted elsewhere in the world, that it is well shows that the 15 milligram per kg per day is in adult and 20 milligram per kg per day in children. Studies conducted in India has used that initial dose of 10 to 15 milligram per kg per day for both adults and children, and clinical and hematological response were observed in adults and pediatric patients at a lower dose, that is 10 to 15 milligram per kg per day. Hence, 10 to 15 milligram per kg per day should be the initial dose among Indian sickle cell disease patients with vaso-occlusive crisis. In patients with renal impairment, we can start a lower dose of 5 milligram per kg per day. Now, how to titrate the dose? So most of the Indian study use fixed dosing, but the study from the Gujarat, they actually started at 15 milligram per kg, and then gradually they escalated the dose to 30 milligram per kg per day. Now, why the Indian study use a lower dose? So there are different causes. The main is that thing that we know that we belong to the Arab Indian haplotype, most of the sickle, and so their baseline hemoglobin F level is a little bit higher. So we might not need that much of hydroxyurea like the abroad to increase the hemoglobin F a little bit. So we can use a little low dose. In addition, there are other practical constraints also, like most of the sickle cell patients in India belong to the tribal group, they belong to the low socioeconomic group, they are in a rural area, so there is a difficulty in the communication, so they cannot come to us frequently for monitoring. So as a result, if we start at a higher dose, they might develop severe myelotoxicity because of the hydroxyurea and end up in neutropenia, and severe neutropenia leading to febrile neutropenia and even sepsis, which can endanger their life. So that's why better to use a lower dose. But there is still unmet need in a randomized control trial comparing fixed dose versus dose escalation to understand the differences in the response rate. So this is the no harm trial. They extended it, and here they allowed the dose escalation. They titrated the dose every 2 months, increased by 5 milligram per kg every 2 months, to up to a maximum tolerated dose of 35 milligram per kg per day. And in this study, they finally conclude that dose escalation of hydroxyurea to maximum tolerated dose showed significantly greater improvement in clinical outcome compared to the fixed dose group. So this trial was stopped early due to unanimous recommendation on benefits of the dose escalation group. So we have to escalate the dose. That is the thing. And different guidelines also say you can increase the dose by 5 milligram per kg every 8 to 12 weeks. Some say every 6 to 8 weeks. In Indian guideline says if there is no major toxicity, try to escalate dose every 6 to 8 weeks by 5 milligram per kg per week. Now, what are the challenges in India when we want to give maximum tolerated dose? Okay, so thing is that again, because majority of our population belong to tribal group and majority are resides in the rural area where communication to the center, treatment center is difficult, and many so we will not be able to monitor them frequently. They cannot come to us frequently. As a result, they might develop severe sepsis and which can endanger their life. And then because of their ignorance, lack of awareness, and also little bit low literacy, there is low health seeking behavior. And many of them belong to the low socioeconomic group and their hygienic also not good. So as a result, if there is a little bit of neutropenia, they're prone to infection and sepsis. So that these are the challenges. So if you want to summarize about the maximum tolerated dose, majority of the studies conducted in India use a fixed dose of 10 milligram per kg per day for both adult and children. Titration to the maximum tolerated dose in a large RCT already showed that it is really good and it really decreases the VOC, SES, and blood transfusion hospitalization. Both Western guidelines and the Indian guidelines suggest to titrate the hydroxyurea to maximum tolerated dose to get the best result of hydroxyurea therapy. And if dose escalation we are going to do, then we have to increase the dose to 5 milligram every 8 to 12 weeks until mild myelosuppression to maximum tolerated dose. Now, what is the maximum tolerated dose? In one study from the Gujarat, they have said that up to 30 milligram per kg per day. Different guidelines shows different maximum tolerated dose, but you can see that the that American guidelines is up to 35 milligram per kg per day maximum dose, and in India also it is NHM says that we can go up to a maximum of 35 milligram per kg per day. We have to slowly increase the dose every 5 milligram per kg every 6 to 8 weeks. So to summarize these findings, we can say that if the dose escalation is warranted and agreed, we can increase the dose by 5 milligram per kg per every 8 to 12 weeks until myelosuppression up to the maximum tolerated dose. Maximum tolerated dose can be considered when there is mild myelosuppression, which is ANC of 2000 to 4000. Dose can be escalated to a maximum of 35 milligram per kg per day until toxicity concerns with hydroxyurea, and we have to monitor the ANC. Now, how to monitor the response to hydroxyurea? Different studies, they have monitored different like clinical outcomes as well as different lab parameters. Now you can see that different guidelines also say some different parameters which be monitored. Our Indian guideline says that we have to monitor the decrease in the pain, increase in the hemoglobin F. We have to monitor RBC, MCV, and fetal hemoglobin level. Okay, to monitor. So how frequently? Some studies says every 2 weeks, some studies says 4 weeks, some studies says every 3 months. These guidelines, like British guidelines says every 2 weeks, we have to monitor the CBCs. American guidelines says every 4 weeks. Our Indian guideline says that we should follow CBC every 2 weeks. If possible, monitor the hemoglobin F every 6 to 8 weeks and blood chemistry every 2 to 4 weeks. So to summarize this finding, we can say that most cost-effective and important monitoring is the clinical outcome, that is the VAC, the VOC leading to hospitalization, and hematological parameter like CBC, MCV, ANC, hemoglobin F. So my take-home message is hydroxyurea should be used in all sickle cell disease patients to start with a 10 milligram per kg per day dose to monitor for clinical response as well as the hematological response, to increase the dose slowly by 5 milligram per kg per day every 6 to 8 weeks until the ANC is more than 2000 and until the results effect is observed. Maximum tolerated dose to be 35 milligram per kg per day. In patients with renal impairment, to start with 5 milligram per kg per day and to monitor CBC serum chemistry every 2 to 4 weeks. If possible, to monitor hemoglobin F every 6 to 8 weeks. Thank you.
Thank you, Professor Ray. So do we have any questions for Professor Ray from any one of the faculty here? There is no question in the question box, the chat box, but anybody from here? Okay, Dr. Rita Singh, go ahead.
Sir, good evening.
Good evening.
In a patient who are not very symptomatic, say they don't have recurrent VOCs, and nowadays if they are coming to us, we are starting hydroxyurea. But in a patient who's totally asymptomatic, at what age would you like to start hydroxyurea?
Yeah, now it is being said that after 9 months of the age, you better to start in all sickle cell disease patients. Homozygous sickle, sickle beta, and SCA, you better to start because long-term effect is much better. Once there is, once the patient starts feeling the painful crises. There's some amount of damage has been occurring in some organ. Okay, not suppose there are microvascular occlusion in lung or in kidney or liver, damaging small part. It will not affect. It will not give any signs or symptom. So, but if it goes recurrently, so that will ultimately damage that organ. So, to prevent that, nowadays said that sickle homozygous and sickle beta 0, especially these two, and if maybe is SC patient, you should start at the earliest to prevent that end organ damage.
And one more thing, what advice will you give regarding conception? Many of these patients are young and they are really keen to conceive. So this is a very big problem. We don't have anything.
I agree with you 100%. So actually, although it is an antineoplastic drug, it can cause fetal anomaly, but quite maybe large number of patients already, actually in developing countries, these data are there that lots of reports are there that patient on hydroxyurea conceived and delivered a healthy baby without any complication. But if you say from scientific point of view, as soon as the patient conceives, better to stop it. And I think the practical thing will be after 3 months when the organization is complete, then we can restart the hydroxyurea.
And what about the males? Like if the wife of a male sickler wants to conceive, then would you like to stop hydroxyurea?
No. It is not. It has been seen that it doesn't cause any problem to the.
Thank you.
Dr. Dibesu, your question.
Hello.
Yes.
Good evening, sir.
Good evening.
I would like to ask how to monitor these patients regarding the hydroxyurea use, regarding the efficacy of hydroxyurea, because most of our patients have VOC symptoms probably 1 or 2 per year. So other than VOC frequency, any other method to monitor the efficacy of hydroxyurea?
Yes, that is that how to monitor response to these other studies. Different studies used different things. Clinically, they are, as you just said, that VOC event, need for hospitalization, quality of the life. These are the clinical parameters you have to monitor. Okay, like how many days they are now abstaining from the school or office, all those things. And lab parameters, different study uses that different things. But the guidelines, they say different guidelines that you have to ideally take RBC, MCV, fetal hemoglobin level. Okay, these things you have to see.
Thank you. I think that's all what we could accommodate. Thank you so much, Professor Ray. We'll move now back to Priyanka. She has been already introduced and she's going to speak to us on improved SCD outcome monitoring beyond hospitalization. Over to Dr. Priyanka.
How can I stop my slide screen sharing?
It is already stopped.
Okay, thank you.
Kalpesh, can you please show the slides from your end?
Yeah, we can see yours.
Yes. So, will you be moving the slides, Kalpesh?
Yes, I am doing.
Okay. So, thank you, Agarwal sir, and thank you, Novartis. I'm sorry to have not been able to deliver my lecture at the time point, but I think the question that was put up by Dr. Dibyendu, some of his questions or his queries will be answered while I deliver my talk now. So, improve sickle cell disease outcome monitoring beyond hospitalization. Hospitalization is something when we come across with the VOCs in a patient who are hospitalized or are coming to the emergency department. What can we do beyond hospitalization? So, before I speak beyond hospitalization, I also will throw some light what are the causes of hospitalization in a sickle patient. Next slide. So, this is my disclosure. Next slide. So, preamble to home management with history of sickle cell disease. How has hospitalization gained its importance in SCD management? Is hospitalization the only factor driving SCD care? And how we optimize this home management and monitoring of the patients beyond VOCs. Next slide. Next slide. Yeah. So to start with, if we look into the history of sickle cell disease, the first person to have been noted to have or to understand the disease was Walter Clement Noel, and he was born in the large estate in Caribbean. He was enrolled to dental surgery in Chicago, and during his stay over there, he had first episode of respiratory problem at 1904, that is at an age of 20 years approximately. He sought for a medical attention, and needed a 1 month of hospital stay. Experienced several illness in the next 2.5 years. He had frequent bronchitis, which we know that sickle patients have a lot of acute chest syndrome and a lot of respiratory illness. Later confined for 2 months of hospitalization with a number of VOC sort of attack. And during that time, Dr. Iron used to call him at home to know what are his pain symptoms and what is his respiratory illness doing during that time. So this is how actually he monitored, in spite of the fact that the patient or me was admitted over there in the hospital. But beyond that, the doctor or the physician who was attending him used to make house calls to understand what was the disease pattern. And later on, after understanding what was the disease and coming into a conclusion that it was a sickle cell disease, in 1910, Dr. Herrick over here, he presented the case in a national meeting, and he did not mention at that point of time Iron, who was actually an intern who was attending Mr. Noel at that point. So though hospitalization is debilitating and most frequently reported or documented in SCD, home monitoring and management has been an integral component of SCD right from the days when we first understood what sickle cell disease was in history. Next slide. So next, how has hospitalization gained its importance in SCD management? We have a few slides on that. VOC resulting in hospitalization and mortality. When we started understanding that VOCs are the most important manifestations which cause hospitalization, hydroxyurea was something which helped in alleviating with these VOCs, and a lot has been discussed about it by Professor Ray in the previous slides. Next slide. So VOC leading to hospitalization, what are the complications and mortality? Continue, please. So if we look into what is the relationship between VOC and the complications, you will find that a number of complications, please keep on flowing the slides. So a number of complications do occur. Acute chest syndrome is one of the most common and one of the most common cause of mortality among the sickle patients. Gallstones when they present with pain abdomen, avascular necrosis, sepsis because of low ANC or the splenic sequestration resulting in low ANC, cardiomegaly, chronic kidney disease, AVNB, fine leg ulcers, pulmonary embolism. A lot of these causes, you will find that one patient may even come up with multiple or organ involvement or multiple episodes of multiple organ damages at a single point of time. And even some patients will have just single organ involvement. So in this study, which was NHS study from England, 15,000 patients approximately were evaluated, and VOC was the most common cause of hospitalization. That is what was documented among these patients. Next slide. Similarly, there are few other journals which have also, like from OnePlus and the Journal of Health Economics and Outcome Resources, where they have shown that the patient having more number of hospitalizations have a higher risk of death and a lot of complications, including ACS, stroke, pulmonary embolism, splenic sequestration, and pulmonary hypertension. Similarly, from the CSST SCD cohort also, they documented similar results. And if you look into at the follow-up data, the death in sickle patients occurs a decade earlier in patients who have number of VOCs are higher than the patients who have fewer number of VOCs. Next slide. So severity, this is what was depicted in NHS England, and there are a few other studies from US, but what is going on in the patients of Indian origin? So as we listen that hydroxyurea is required in a lesser dose at 10 milligram per kg because of the Arab Indian haplotype. Similarly, you have to document our own patients, and we have to have our own guidelines so that we do understand that our patients are a little bit different from the patients of the West. And if we look at the data, there are number of studies which are reported from Odisha, Maharashtra, Chhattisgarh, Gujarat, and MP, which are the predominantly affected areas of sickle, where you can see even in India, the most common causes of hospitalization are pain, VOCs, and among that, musculoskeletal pain or the bone pain or the joint pain accounts for approximately 80% of the cases. And apart from that, whatever are seen as VOCs or the organ damage in the West are also seen in the patients, in our patients of Indian origin. Next slide. Next slide. So hospitalization, as I said, in Indian patients also, it is 50 to 90% based upon what is the percentage of the HPS in a patient. And VOC resulting in hospitalization is associated with increased risk of mortality and morbidity. Though the data on VOCs resulting hospitalization are most frequently documented, it is still the tip of the iceberg in SCD because we will be talking about the amount of the VOCs patients experience at home in the next few slides. Next slide. So next is hospitalization the only factor which drives SCD care? Obviously no. Next slide. So if we look again into the Western data, then we find that in a sample of 303 patients in US with SCD who completed an online survey, patient answered the questions regarding their experience on the VOCs with SCD. 51% were managed at home itself. And in US, where the healthcare system is so much robust and where patients have the ability to move to the hospital at their earliest, but still you can see that there is a significant proportion of patients who are managing their VOCs at home. 18.4% are managed at the primary care doctor's office, possibly in the biophysicist or a pharmacist. Top 3 most urgently used treatment measures for home management were non-narcotic analgesics 61%, mild narcotic analgesics of 63%, and strong narcotics of 44%. And what was the reason for management of pain at home? 76% felt that they knew how to treat their pain because the number of pain episodes and when they moved to the hospital, the same format they follow at home. 35% experienced that their pain was mild and 20% expressed that the treatment was expensive. So these were the reasons why the patients preferred to take analgesics at home rather than going to the hospital. Next slide. If we look into the Indian data, also there are similar findings, but before that, the SWAY study, that also was a global study, and 11,307 VOCs reported. 48% of them were managed at home or at community center. Emergency only 19%, overnight hospitalization 33%. So 48 out of that, 48 means approximately 50% were managed at home and at community level. Next slide. These are all recent data of 2020. Next slide, please. So in the low medium income countries, the data also is similar to that of the global SWACE surveys, and the reasons, as I said, poor experience at hospital and emergency if the patients of SCD are coming, and that is what even we experience in our centers, that whenever a patient of sickle comes, they are the ones who are least attended, and the other patients are taken up as a priority basis. So that is something which also does not allow the patients of sickle cell to come to the hospital or come to the emergency, and they're trying to manage the episode of VOC at home itself. The perceived medical assistance is not necessary. They feel that the number of admissions when they have into the hospital, that is sufficient enough to take care of, and they know that how to manage it at home itself. And hospitalization too expensive is always that is always a cause. If the patient comes to a private hospital, definitely he has to pay out of his pockets. So management strategies, they take rest or sleep, take adequate fluid, topical pain medications, and opioid analgesics if it is available to them, or else in India, the NSAIDs are the ones which are most frequently used. Next slide, please. So VOCs occurring at home or managed at community significantly impacted all domains of patients' life, because when they analyzed the data, they found that SCD interferes with the daily activities, with family and social life. Patients feel stressed, there is low attendance of the students at school, and they have impaired ability if they are going for a job. Next slide. So this was a very beautiful study actually I went through, and this is known as the evaluation of longitudinal pain study in sickle cell disease by patient-reported outcomes, actigraphy, and biomarkers. Next slide. This is only in 2021 this was published, and this, if I want to actually read through whatever is highlighted over here. This non-interventional longitudinal 6-month study aimed to develop tools to identify VOCs in patients with or without healthcare utilization. Participants wore an actigraph device tracking sleep and activity. Patients with SCD used an electronic patient-reported outcome tool to collect data on pain, medication, fatigue, and daily function. patients self-reported when they experienced VOC pain, and that was known as VOC day. Biomarkers were collected every 3 weeks on the non-VOC days. Self-reported VOCs triggered at home or in hospital blood collection, and it enrolled only 37 patients. I will like to mention that even to trace a single patient of sickle, it is very difficult. So 37 patients also, if they are strictly followed and this monitoring is done, it definitely provides a huge impact. And participants reported 114 VOC events and 346 VOC days, of which 62 and 78% were self-treated at home. So apart from hospitalization, a lot of emphasis has been given to VOCs which are being managed by the patients at home itself. The EPRO, that is the electronic patient patient reported outcome, and actigraphy captured endpoints of pain, functionality, fatigue, activity, and sleep. Each was significantly altered on VOC days compared with the non-VOC days, and biomarkers were analyzed like from the baseline, like the leukocyte platelet aggregates, microfluidic based blood cell adhesion, interleukin 6, C-reactive protein, interleukin 10, TNF alpha, thrombin, and antithrombin. And what this study or the trial showed that in patients who are undergoing clinical trials, these biomarkers and activity can be a very good endpoint of assessment to know the outcome of whatever the new drugs are coming into, so that we can actually know the decrease in burden of the VOCs, be it regarding hospitalization or management at home. Next slide. So this was the schematic study design. What I meant to say over here, they have defined VOC event as VOC day is any pain they have experienced at any point of time on a day. And VOC event is whenever this VOC is not present in at least 2 consecutive days. Here you can see right from day 2 to day 12, there has been no 2 consecutive days where the patient did not have a VOC. So the whole episode was considered as a VOC event. And when there was a break of 2 days, after that, if a patient experiences VOC, that is going to be the start of another VOC event. Next slide, please. Next slide, please. Yes. So over here, you can see that the thing which is to be emphasized, self-treatment was approximately among 78.3% of the VOC days and 62% of the VOC events. So most of the patients got treated at home itself. Next slide. And all VOCs and all at-home VOC day pain scores were significantly higher than the non-VOC pain scores. It definitely reduced the physical, social, and functionality scores. Reduced for the self-care functionality was significantly reduced for all VOC days, and fatigue score was higher when the patient experienced VOC. Next slide. The importance of this study was how do we monitor a patient whether he has VOC or non-VOC when a patient is taken up for trial or when you are trying to analyze your patient. So what are the patient's expectations from a physician? In that study, the global SWAY survey, they concluded that the most commonly selected treatment goal was to improve the quality of life of the patients, and other treatment goals were prevent worsening of SCD, reduce the number of severe pain crises, improve overall symptoms, and the long-term survival. Next slide. So VOC at community and home level, maximum the patients were managed at home, and that is why it also impacted the quality of life. And it is important to monitor and address all the VOCs, be it managed at hospital or at home or community level, using a structured monitoring format since patients desire to have an improved quality of life. Next slide. So the last point which we have to mention now, apart from the hospitalization and how to monitor, we have to know how to optimize the home management and monitoring of these patients so that the burden in the hospitals is less. Patient has an improved quality of life if they are managed at home. The reduction in the VOCs and reduction in the end organ damage. Next slide. So the key components to it are adopting the patient-centric approach for home management of VOC, and this is what is known as participatory medicine. In patients with SCD, VOC needs to be monitored, overall quality of life has to be seen, supportive therapy, pain management, nutrition is a huge part, and we listened to the previous talks over there, that how the government is trying to improve the nutrition in the patients of sickle, so that also the number of the episodes and the average nutritional status is good. Education and counseling to patients, family and school. So this has to be taken care of, and it is the responsibility not only of the healthcare professionals, but the government as well as the patients, as well as the advocacy has to be done over here. So next slide. So I think many of us are aware of this chart. Actually, after the number of the CMEs we have been through in the last 2 years, I think we have tried to understand how to monitor VOCs, how to explain to our patients how to monitor them. There are some e-diaries which are being given to the patients who are able to use phones or who are updated with the with these apps, so that we can record the number of VOCs. We can understand the frequency and duration of the days they are having VOCs, what is the intensity of pain right from 1 to 10 score, then what are the interventions which have been taken, whether the patient has taken any analgesics, medications, how the hydration status has been, whether the patient has visited the hospital or managed it at home itself, the duration for which the pain has been there, what are the areas of the body which are affected. This is to be given to the patient, so that for every episode of pain, he can have this documented, and once this is documented, a physician also understands that the therapy which is being instituted to the patient, whether it has been able to produce some usable outcome to decrease the number of the VOCs. So next slide. So quality of life, that is what will impact if a patient is managed at home at the earliest, and that will be able to increase his daily activity, mobility, increase the physical activity. As we saw, the children were not able to go to the hospital. Self-care has to be incorporated as a part of their own care for the patients. They should know what they need to do at the onset of a VOC or when there is a prodromal phase. Work and schooling, emotional and psychological functioning. We heard the patient saying that how down they feel when there is an episode of pain. Social functioning. So these are all which will impact the quality of life of these patients. Next slide. The role of supportive care is very important. Dehydration needs to be avoided, and the recommendations are to take adequate amount of fluids, and fluid replacement to maintain euvolumia during VOCs is very important. You should not ask a patient not to exercise, but to take adequate fluid as well as to exercise, so that they have reduced amount of deformity or reduced pain. Next slide. Next slide, please. Environmental factors like temperature and all, most of the time patients themselves are aware that the variations in the temperature are precipitating their VOCs. So we should advise them what are the proper measures to be taken whenever the winter sets in or when the summer is high and there is more amount of sweating, to take adequate amount of fluids. Next slide. So nutrition, as I said, malnutrition contributes to worsening anemia, general poor health, increased risk of infection. This is something with the help of the government we will be able to take care of this. Nutrient dense diet and personalized diet are important. Adequate fluid consumption, micronutrients which are important as they are helpful in alleviating the amount of the micro or the malnutrition. Omega-3 fatty acids, they also have a very high role to play so as to prevent the damage to the RBCs. Next slide. So this is my penultimate slide. The role of education and counseling in sickle cell management. As I said, patient advocacy, NGOs, community leaders, government involvement, they all play a vital role, and that is a key component in awareness about the disease. Awareness about the disease management, not only the healthcare physicians, but also the sickle cell disease counselor, the ASHAs, patients, and the families themselves should be aware of how to manage this disease. Social rehabilitation, again active involvement by government, healthcare practitioners, patient group, family, patient, as well as the advocacy. All of them will have a very important role in order to train the sickle cell counselors and to bring about a change in PCD management. Last slide. So training of the patients is important, and fever or infection has to be taken care of. Hospitalization whenever required, ACS, clinic sequestration, stroke, hemolytic crisis, vomiting, diarrhea, At the earliest, patient needs to be hospitalized and taken care of so that end organ damage is least. Next slide. So this is my take-home message. Sitting home management, adequate VOC and disease monitoring is required. Avoid the environmental triggers. Important to have multi-stakeholder approach. SCD counseling and role of trained SCD counselors is of immense importance in order to improve the overall outcomes. That is where we come beyond hospitalization. Next slide. So that was it. Thank you very much for your patient hearing, and any questions I would be happy to take up.
Thank you, Professor Priyanka Samal. In the interest of time, we will move to the next speaker. We have now our guest speaker, Dr. Irfan Noor. He's consultant hematologist, Department of Hematology at the Amsterdam University Medical Center, the Netherlands. And he's going to speak to us on rethinking the sickle cell disease management with newer therapies, the real world experience. So over to you, sir, Dr. Irfan Noor.
Yes, thank you very much. Can you hear me?
Yes, very well.
Okay, thank you. So it's a great pleasure to be here, and thank you for inviting me to join this esteemed faculty. As you introduced, I will be talking about the latest developments in treatment options and hopefully some of the real-world experience that I can share with you. So before I go into the treatments, I would like to shortly touch upon the clinical picture of this devastating disease, just to, I think, really make the groundwork before we go to the treatment. So in order to understand how devastating the disease is, I'm sure most of you know this. And then I will shortly discuss the pathophysiology, because most of the pathophysiological mechanisms are the targets for these therapeutic approaches. So this is a real-life patient, Ms. E, who is now almost 30 years old, and her childhood was characterized by frequent vaso-occlusive crises, which really disturbed her life, caused school absenteeism, and then that also really had a deeply negative impact on her psychological well-being and social functioning. After transition to the adult care, she continued developing these events, which were oftentimes complicated by acute chest syndrome, severe acute chest syndrome, for which she had to be admitted to the intensive care and receive exchange transfusions. And this cascade of complications continued with avascular bone necrosis of both her hips at very young age, around 26 years old, for which she had to undergo total hip replacement of both sides within 1 year. Yeah, she also developed pulmonary hypertension, which we know is a sign of accelerated degeneration and extreme severe disease. She later also developed necrosis of both her knees, for which she hasn't had replacement yet. And these complications really developed one after another, despite treatment with hydroxyurea and later also exchange transfusion and even a combination. So this is a patient who at that time we really didn't have good treatment options for. Currently, she has fortunately more options, but she had fortunately also had an HLA identical sibling, for which she has undergone a allogeneic stem cell transplantation some 3 years ago, and that has really stopped the development of complications, both acute and chronic, but unfortunately maybe a bit later. So sickle cell disease, as I think was also elegantly described by the previous speakers, is a very heterogeneous disease. So a patient with homozygous sickle cell disease with almost the same age can have a very different presentation on a spectrum of hemolytic to vaso-occlusive. So you might have two patients at your clinic of almost the same age with the same genotype, but very a different presentation of low hemoglobin on the one side, relatively higher on the other side. The one with the higher hemoglobin might have more painful events and also acute chest syndrome, for which this patient had to have transfusions resulting in iron overload, and also developing hip necrosis. The patient with the lower hemoglobin is more hemolytic and also has hemolysis associated organ complications such as leg ulcers, which can be very refractory to treatment, a nephropathy, which is a first sign of renal insufficiency. And if you do an MRI scan in this hemolytic patient, you have a very high risk of seeing silent infarctions if this patient hadn't had overt stroke at a younger age. So shortly, the pathophysiology, I think this image really elegantly describes the whole cascade, the vicious circle of vasculopathy. I think we call it hemoglobinopathy, but it's much more a vasculopathy. And so this image shows that, of course, it begins with a polymerization of sickle hemoglobin, which then results in the sickling of red cell disease, red blood cells, which then gives rise to hemolysis. And hemolysis, of course, as you know, gives release to the redox active heme, and especially iron, which catalyzes the production of reactive oxygen species. And that's a very, very important and central mechanism of pathophysiology in this disease. So this oxidative stress gives rise to downstream inflammation, resulting in cytokine release, neutrophil activation. And this inflammation then also contributes, together with the oxidative stress, to activation of the endothelial cells, then which gives results in a production of adhesion molecules, which play a very important role in the pathophysiology of vasoocclusion, because as you can see here, white blood cells, but also red blood cells and even platelets adhere to these adhesion molecules, and then that results in vasoocclusion. And it doesn't end there. Once there is reoxygenation, there is a very important ischemia reperfusion injury, because of the there are some enzymes which are activated upon hypoxia, and once there is oxygen delivery again, that also results in increased production of oxygen, reactive oxygen species. So this vicious circle goes on, and that results in both acute and chronic complications, from painful events to acute chest syndrome to priapism and stroke, but also to chronically developed organ complications in almost every organ of the body. So when we try to make a treatment decision, it's important to consider both patient-related and treatment-related factors. So you have to know what the genotype is, because not every genotype reacts the same to every treatment. And you also have to know, is this a more hemolytic type of patient or more vasoocclusive? And what are the complications that you want to treat or prevent? And what are the treatment options? I think the previous speakers also talked about, for example, the hydroxyurea. Is it available in a rural area? Can you monitor it well? So what's the care network, and what is the impact on social life, on work, and really psychological well-being, which is, I think, a bit ignored in many patients. That's something that we really have to give more and more attention to. So the treatment options that we had until recently were supportive care, hydration, keeping warm, and rest, especially when patients have pain, and then analgesics, opioids, and established treatment that has been applied for many years is blood transfusion, top up or exchange, and dietary supplements, for example, folic acid, vitamin D in some countries, and then hydroxyurea, which is really underutilized still. So just let me shortly touch upon the transfusion. There is abundant evidence, especially from the STOP trial, which showed that it caused transfusion, chronic transfusion, periodical transfusion, resulted in a very significant decrease in the risk of stroke in patients who are at risk of stroke as compared to placebo. So pediatric patients who have a TCD measured blood flow velocity of more than 200 centimeters per second are at increased risk of developing stroke. So these patients were rescued from developing stroke with transfusion. But there's also evidence, clinical practice evidence that it can prevent acute complications. And so, for example, before operations or with acute chest syndrome, priapism, and chronic transfusions are given as a prevention, as was in STOP trial, to prevent stroke. Sometimes to develop pregnancy-related to prevent pregnancy-related complications. Sometimes patients have very debilitating, painful events that, for example, the patient that I presented. So also then you can decide to give chronic transfusions to prevent next VOCs. Other complications that can be treated with transfusions are acute chest, priapism, but also a rare complication, but very serious complications is vaso-occlusive hepatopathy. But transfusion is not without risks. Of course, it causes iron overload if you give top-up transfusions. Other reactions that we here in the West see more, perhaps because of the racial mismatch, is red blood cell alloimmunization and also delayed hemolytic transfusion reaction, which is really a very serious complication that makes next transfusion almost impossible. Hydroxyurea, Professor Ray elegantly explained most of these things. Just shortly, it causes induction of fetal hemoglobin, and this was shown in a randomized controlled trial that it significantly decreases the annual rate of painful events, which was 2.5 per year compared to 4.5 per year in placebo. And the time to first and second vaso-occlusive event was much longer in the hydroxyurea arm as compared to placebo. Of course, as in many medications, not all patients respond well, and unfortunately some of the patients don't take it, don't want to start it, and more importantly, many more patients don't have access to it, as was also discussed, and also more and more trials show that pediatric patients also benefit from hydroxyurea. So it is to prevent complications, to prevent a serious or chronically developed organ complications, it's good to start as early as 9 months. And then the new treatment options that have emerged in the last few years. I will shortly talk about L-glutamine, which is an antioxidant, not very new, but has been shown that works as a treatment for sickle cell patients as well. The monoclonal antibody crizanlizumab against P-selectin, and then the HBS polymerization inhibitor compound voxelotor. There are also some encouraging developments in gene therapy. Two important concepts. One is the lentiviral construct that introduces a gene, beta-globin gene, that results in decrease of HBS and then vaso-occlusive events and other SCD related complications. This lentiglobin treatment was very successful in thalassemia, but in sickle cell disease, there were 2 patients with myeloid malignancies, which has risen important safety concerns. And then the CRISPR-Cas9 mediated gene therapy, which induces HbF. This is the CTX001. And there was a recent update on this study at the EHA in Vienna just more than 1 week ago, that there were 31 patients presented who were treated with this gene therapy. There were no safety issues yet, but this is very short term, and patients had a significant increase in HbF levels and didn't have any vaso-occlusive events anymore. But still, it's very early. And these patients, we have to remember, all patients with gene therapy have to be pre-treated with high dose of busulfan, which is myeloablative, and that can have some potential long-term complications. So L-glutamine is an amino acid that targets vaso-oxidative stress, as I just mentioned, is a very central mechanism in pathophysiology of sickle cell disease because of the hemolysis, because of the ischemic reperfusion injury. And the increased oxidative stress gives rise to increased consumption of antioxidants, both enzymatic and non-enzymatic. And one of the important antioxidants is intracellular is NADH, so the reduced form of NAD, which is a nicotinamide adenine dinucleotide. And by providing more L-glutamine, you have more NAD, which then shifts the ratio towards NADH. And so then you have more antioxidants to combat the ongoing production of oxidants. And this was shown in a phase 3 randomized controlled trial that treatment with L-glutamine resulted in 25% reduction in vaso-occlusive frequency and 33% reduction in hospitalization in treated patients. So then the crizanlizumab, the SUSTAIN trial, which was a phase 2 randomized placebo-controlled trial, showed that crizanlizumab in the higher dose, 5 milligram per kg, resulted in a significant decrease in annual rate of VOC as compared to placebo. And also here, the time to the first vaso-occlusive crisis, which was significantly longer in the treatment arm as compared to control arm, and the frequency of adverse events was comparable between placebo and crizanlizumab. Phase 3 trials, which also study higher dose of 7.5 milligram per kg, is still ongoing, but based on this study, this crizanlizumab was approved by FDA and also conditionally approved by the EMA in Europe, and I think it's also approved in India and many other countries in the world. The voxelotor, which is an anti-sickling compound, this was studied in the HOPE trial, phase 3, also placebo-controlled. It showed that there was a significant increase of 1.1 gram per deciliter in hemoglobin in a large proportion of treated patients, while there was no difference in the placebo arm. This didn't result in a decrease in painful events, but of course this study was not powered for that. Post-marketing real-life studies show that some 25% of treated patients also have important decrease in the rate of vaso-occlusive crisis. Also, again, here, no differences in adverse events between the treatment arms. So these treatments really give more options to us to improve the quality of life of patients and also perhaps slow or limit or hopefully stop progression of organ complications. But there are patients who still develop complications. So there are patients who are treated with chronic transfusions but still develop silent cerebral infarct. So those patients really might benefit from curative treatment options such as allogeneic stem cell transplantations. The best donor would be a matched sibling donor. Results with this transplantation have been very, very good, with very low rate of treatment-related complications. But unfortunately, only around 18% of patients have a matched sibling donor. So then there is the haplo-identical stem cell transplantation, which has been gaining ground in the last years. So you can use a father or a mother or son or a half brother, half sister. So that gives you really many more options. And that's what we have been doing also in the Netherlands. And one of the important issues with these transplantations was the conditioning regimen, which was myeloablative previously, especially in children. That gives rise to important complications, especially in adults. So there have been modifications in the conditioning regimens, which has resulted in reduced complications while keeping the rate of graft failure at acceptable rates. So the idea is to try to add some immunomodulating agents instead of myeloablative agents. But as I mentioned, the myeloablative conditioning regimen is toxic especially for adult patients, because they have an accelerated development of organ complications. So myeloablative conditioning regimens have been very toxic in adult patients. And so attempts have been made to develop non-myeloablative conditionings. This is one of the first conditioning regimens that was relatively successful. It exists of alemtuzumab, which is an anti-CD52 agent. It depletes T cells and B cells in combination with TBI of 3 gray. It's a very mild conditioning, and this resulted, interestingly, in a mixed chimerism. So patients continued keeping a fraction of their own chimerism, especially a large proportion of their T cell chimerism, but that was sustainable in a large part of patients. But as you can see, around 13% of patients had graft failure. And there was a follow-up study of 3 hospitals, 3 centers, the NIH, Chicago, and in Saudi Arabia, of 122 patients, which confirmed this 13% rate of graft failure. And also around 10% of patients had to continue using immunosuppression in order to prevent secondary graft failure. So that's not very attractive to be using sirolimus, which is a very toxic drug for many, many years. So that's why we thought there are, so the reason that there is high risk of graft rejection in sickle cell patients is because these patients have a very expanded bone marrow. They have to produce a lot of red blood cells. That means the bone marrow is very active, which makes for an unfriendly environment for the new stem cells to engraft. These patients have a triggered immunity because of the chronic inflammation. And in contrast to patients with malignant diseases, they haven't had a pre-treatment. So these are reasons we think that increase the risk of rejection. So these are some unpublished results, at least they have been shown in medical meetings, but not published yet, of our center. So we thought, how can we reduce this risk of rejection, taking into account the mechanism that I just showed you? So we thought maybe adding a preconditioning with azathioprine and hydroxyurea might reduce the risk of graft rejection. Azathioprine, as you know, is a T-cell treatment. So by this, we try to decrease the triggered immunity. In hydroxyurea, if they were not treated already, we give this to them during 3 months in order to suppress the bone marrow, to decrease the expanded bone marrow. And we have treated 20 patients until now. And as you can see, most of them were homozygous sickle cell patients. And you can see the organ complications that they had, which were mostly vaso-occlusive crisis to stroke and to hepatopathy, priapism, almost all complications. And these are the results of the 17 patients of which we had chimerism. So you see here donor myeloid chimerism and donor T-cell chimerism. For comparison, I will show you the previously published results of the earlier study without this preconditioning. As you can appreciate, it's of course not a very you can't compare these head to head because there were several different populations. But as you can appreciate, we have a higher myeloid chimerism and, more importantly, higher T-cell chimerism of around 80% as compared to around 50% in the previous study. And of the patients who have reached 1 year target, we have been able to discontinue sirolimus in all these patients. So that's very encouraging, which is in contrast to the 8% in this study. And we have had only 1 graft failure, which also seems to be lower than the 13% in the previous study. So this is encouraging. We will have to go further to see if we really have a lower graft failure and also a higher percentage of patients who can stop their immunosuppression. And these patients had gradually developed normal hemoglobin levels and normalized hemolytic parameters, which is very nice to see, and a very significantly improved quality of life, which we also are studying. And then last treatment option that I want to touch upon is these are new developments. Studies are going on. New insights show that pyruvate kinase activation is decreased in sickle cell patients, as is also in other hemoglobinopathies. The first insights come from the pyruvate kinase deficiencies. So decreased pyruvate kinase activity means lower ATP levels, and that means higher levels of 2,3-DPG. We all have 2,3-DPG in our red blood cells, which is very functional. It means that they stimulate deoxygenation in tissue. So that means we can our red blood cells in health can deliver oxygen. But in sickle cell disease, these levels are increased. That means that they will more readily release their oxygen, and that means they will deoxygenate and so sickle, because as you know, sickle hemoglobin polymerizes once it is deoxygenated. So by giving pyruvate kinase activator, you can decrease the pyruvate kinase activity, meaning increase production of ATP, and that will decrease the 2,3-DPG levels, and that will mean in a more vital, more lively red blood cell, which will live longer and which will sickle, which will not sickle as quickly as without this treatment. And there are 2 compounds in study. The first is etavopivat. These results were shown at the ASH meeting of last December. As you can see, patients had a significant increase in hemoglobin levels, of course, because of primarily decrease in hemolysis, as can be seen here with absolute reticulocyte counts, decrease in bilirubin and LDH levels. And this also seems to result in decreased inflammation, as you can see the TNF alpha levels decrease significantly compared to baseline, and also decreased activation of coagulation, as can be seen with a decrease in prothrombin 1,2. And another study here in the Netherlands of our consortium, which we also are part of, with mitapivat, a very small study. These are the results of the first 8 patients that showed that treatment with the mitapivat results in a decrease in point of sickling. So point of sickling is a new measurement that shows that red blood cells can cope with lower oxygen levels. So that's very encouraging. And also the ATP to 3 DPG ratio increased, meaning higher levels of ATP and lower levels of 2,3 DPG. And also here you can see the increases in hemoglobin levels of the individual patients, ranging from 0.4 to almost 2 grams per deciliter. And these are the mean increases in hemoglobin and decreases in hemolytic parameters. So very encouraging. I think this has great potential from which we will hear in the next years. So in summary, these new treatment options can significantly decrease disease burden, so improve quality of life. But first we have to focus on increasing the availability of the already available, already existing drugs like hydroxyurea. And because we have more treatment options, we have to go towards personalized medicine also in sickle cell patients. And despite these treatment options, some patients will continue progressing, developing organ complications. And those are patients that have to be considered for curative treatment options. I think there are very important developments in allogeneic stem cell transplantation, especially with the development of less toxic conditioning regimens, especially for adults, of which I showed you some results of our center. And gene therapy has great potential, but it's still too early to call. There are concerns of off-target effects, especially with the CRISPR-Cas, and also there are some, as I said, 2 reports with the Bluebird Bio of clonal hematopoiesis. So we have to keep an eye on that. So with that, thank you very much. I'm ready to answer your questions.
Thank you so much, Dr. Irfan Noor, for that lovely comprehensive talk on the newer therapies, updating us right to the present data. Are there any questions for Dr. Irfan Noor from anyone over here? There are no questions in the question box or the chat box, but the faculty here, you want to ask him anything? All right, just one quick question I will have. How do you decide about adding crizanlizumab to your patients who are already on hydroxyurea? Who out of them becomes a candidate for adding crizanlizumab?
Yeah, thank you very much. Excellent question. I think in the Netherlands, our group of physicians who treat sickle cell patients, we think that has to be a first criteria that patients should have used hydroxyurea, and if they don't have response or insufficient response, then you can add. So I think they excellently go hand in hand. So I think the newer phase 3 studies will show us if there are big differences between in the degree of effect between patients with or without hydroxyurea. But I think they can have additive response, whether it's synergistic or less pronounced, remains to be seen. But we think if they don't have side effects and they have increase in HbF level, it should be combined.
Thank you. Do you have occasions where you had to put them on crizanlizumab because of the toxicity of hydroxyurea?
We haven't had, but that I think that's one of the indications to if the patient is primarily suffering from vaso-occlusive events and hydroxyurea. Sometimes, of course, hematological toxicity, but I don't know if someone has seen this. Adult patients really have sometimes, especially with the higher dose, have another kind of pain, nagging chronic pain, especially in the back, which prevents us from giving higher doses. So then that's I think an indication to switch to crizanlizumab.
Thank you. We'll take two more questions for you, one from Dr. Ray and one from Dr. Dibandhu. Dr. Ray, go ahead. Quick, short question. We can't hear you. Unmute yourself.
If a patient of sickle beta thalassemia was quite well doing on hydroxyurea, but developed bicytopenia, absolute neutrophil count is also less than 1,000 and platelet count came to 50,000. I have to switch to crizanlizumab, but now the patient hemoglobin has gone down actually. So what to do?
Yeah, that's a very important question. So I think it's a difficult one because the hydroxyurea really can increase hemoglobin level because of the decrease in hemolysis, which crizanlizumab doesn't do. So I don't have really clear-cut answer, but you could try a combination with a maybe lower dose of hydroxyurea, which especially in the compound heterozygous with thalassemia can have some results.
Thank you. Dibandhu, your question.
Hello, sir. A lot of center uses heparin or low molecular weight heparin during the sickle cell crisis. So, any experience from your side?
So we also do use a low dose of unfractionated, fractionated, like fraxiparin of 0.3. That's because of the increased risk of thrombosis, especially because they are bedridden during the treatment. So we don't give it because it might have some role on the vaso-occlusive crisis itself, but just as a prophylaxis of thromboembolic complications. And there have been some studies with heparin-like medications, also at our center, cefoperin, and it was a part of the heparin which has a selectin inhibiting role, and unfortunately they didn't have any effect on the duration of vaso-occlusive crisis itself.
Thank you. So thank you so much, Dr. Irfan Noor, for being with us, sparing your very valuable time and educating us. We have almost audience from large number of countries who have logged in and listened to you this evening. Thank you so much.
Thank you for having me. Thank you very much.
We'll move on to some Indian experience now related to the newer therapy, especially crizanlizumab. And may I invite Dr. Abdul Mazid. It's a pleasure to introduce him. Dr. Abdul Mazid is Professor and Head Department of Family Medicine at Government Medical College, Kozhikode. So over to you, Dr. Abdul Mazid. Dr. Abdul Mazid. Okay, till we get a response from him, I think we can move on to Dr. Amit Khurana. Amit Khurana is hematologist, hematologist and transplant at Surat. So Amit, we can have your presentation.
Yes, sir. Let me share the screen, sir.
Yeah, please.
Hello, good afternoon. Hello, can you please start my video, sir?
Dr. Abdul, we will come back to you after Dr. Amit Khurana. Just 5 minutes.
Okay, right.
Good evening, all of you. Thank you, Agarwal sir, for giving me this opportunity to present with this experience of crizanlizumab. I will go with a case study. Can you see? Yeah, okay. Yeah, I will go with the case study. This is case one, a 28 years female, married from Surat, hemoglobin SS, history of repeated painful vaso-occlusive crisis around 3 to 4 per month, requiring NSAIDs and opioids, history of acute chest syndrome, about 3 to 4 episodes in the past. She is on folic acid and hydroxyurea 25 milligrams per day. Her first pregnancy was uneventful. Now she is pregnant for the second time. So her hydroxyurea was stopped on ecosprin 75 milligram after 12 weeks of gestation. Up to 28 weeks of gestation was given. She was put on prophylactic injection LMWH during hospital admission as per RCOG guidelines. During pregnancy, again, she had repeated painful VOCs and 2 to 3 episodes of acute chest syndrome. 1 episode of transient ischemic attack. Repeated painful VOCs were managed with, again, NSAIDs and opioids. Exchange transmissions were done during episodes of acute chest syndrome and TIA. She delivers a very healthy female baby at 38 weeks of gestation by LSCS. After delivery, she is put on hydroxyurea, folic acid, and prophylactic LMWH for 6 weeks postpartum. She continues to get repeated painful VOCs, hampering her quality of life. Patient has been now put on monthly injection Rivanna since last 2 years. Dramatic reduction in painful VOCs, only 1 episode in last 2 years. The quality of life has improved. She is able to carry her daily activities. Both her children are hemoglobin S trait. The patient is happy, children are happy, husband is happy, and hence I am very happy with injection Rivanna. I'll move to the second case. 21 years made from Valsad, nursing student, hemoglobin S beta thel, presence with painful vaso-occlusive crisis, with history of 2 to 3 painful VOCs per month, started on hydroxyurea plus folic acid because he was not on hydroxyurea before. After 48 hours, he developed stroke with ischemic infarct. Exchange transmissions were initiated to bring hemoglobin S to less than 30%. The patient improved and was discharged. The patient has been advised for monthly injection Rivanna, which he is taking since last 6 months, doing well, no VOCs till date, and presently not on only exchange transfusion or simple transfusion programs. The patient and his relatives are happy, and so am I. He is now practicing male nurse in my hospital and looking over to other sickle cell disease patients in my hospital. Thank you.
Thank you, Dr. Amit. In this session, we will have questions at the end of all the presentations. So we'll now come back to Dr. Abdul Mazid.
So,
who is sharing your screen? You or?
Sir, can you share my
Yes,
slide,
please, please do that. Yeah, we can see your screen.
Okay. A very good evening, sir. And to all, see, as a part of clinical trial, now we have, next slide, please. Next slide, please. Next slide. As you know, sickle cell disease is a life-threatening disease with severe morbidities and represents a major unmet medical condition, and also have a negative impact on the mental health of the patients, which leads to depression and anxiety. Yet there is only symptomatic treatment available for the patients with sickle cell disease rather than treating the root cause of VOC. Crizanlizumab is the first new drug treatment for people living with sickle disease to help them prevent the root cause of VOC events. Next slide. So, as you know, the crizanlizumab is the monoclonal antibody, humanized monoclonal antibody against B-selectin, and this reduces the frequency of this vaso-occlusive crisis in patients with sickle cell disease. Crizanlizumab binds B-selectin on endothelial cells and platelets, preventing the interaction with P-glycoprotein ligand 1 and then on endothelial cells and platelets and red cells and leukocytes, and preventing interaction and the formation of the clot and leading to the vaso-occlusive crisis. Next slide, please. Next slide. Next slide, please. Next slide, please. Next slide.
Dr. Abdul Majid, are you there with us? Okay, some technical issues. So we'll move on to the third presentation. That is by Dr. Anil Khatri, who is pediatrician, Ansol, Ahmedabad. Dr. Anil, over to you.
Yeah. Good evening all, and thank you, Dr. Agarwal. It's always such a great learning experience to be part of webinars on SCD. May I have my slides, please? Well, I haven't had much experience, but one which I would definitely like to share is about a patient. Next slide, please. A 22-year-old male, weight about 55 kg, a known case of sickle cell disease on hydroxyurea since 5 years and supportive medicines. Had an average of 4 to 5 EOCs every year and history of 8 hospitalizations in the past 30 months. He also has a family history of death of an elder sibling at the age of 15 years due to chest complications, query acute chest syndrome. Because of recurrent VOCs, he couldn't complete his education and thus was forced to take up a job of a loading rickshaw driver. But because of frequent hospitalization, he could not maintain a good job profile and had to compromise with his salary. He just got married a year back, but had to be content with an unhappy, frustrated wife. Next, please. If we talk about his current status, he has so far taken 14 doses of crizanlizumab over the last 15 months and has had just 2 episodes of mild pain, which was relieved within 2 days with simple paracetamol. And he had 0 hospitalization during this period. He has a highly improved sense of well-being and efficiency as well. Next, please. Social impact has been great. He has become regular in his job. He has saved some money and now, in fact, is planning a family. In patient's words, this injection has changed my life forever. And he is eternally thankful to Novartis for providing him the doses in a familiarization program. Next. To summarize, crizanlizumab, it seems, is proving to be very effective in patients of SCD who do not show optimal control with hydroxyurea and is a boon for them, as well as those who are unable to take hydroxyurea due to toxicity. It is thus a very promising drug, and every sickler who genuinely needs it, I think, deserves it. Thank you.
Thank you, Dr. Anil Khatri, for that exciting case presentation with such fantastic benefits. Dr. Ashutosh Panigrahi from Bhubaneswar is Assistant Professor, Department of Medical Oncology and Hematology at AIIMS there. So your cases, Ashutosh.
Thank you, sir, for giving this opportunity. So, age cost is the main hindrance for utilization of this very good drug. So that's why I have also very less.
The voice is feeble, Dr. Ashutosh. Can be closer to the mic.
It is audible? Now it is audible, sir?
Much better, yeah.
Yes, sir. So I have only a short experience with crizanlizumab. Only 2 patients I have, those in whom I have used crizanlizumab. So because it is not freely available, our institute has not as a part of this trial also. So that's why this is a shopkeeper, 27-year-old male from tribal Odisha, diagnosed sickle cell disease at 7 years of age, not requiring transfusion, but history of acute chest syndrome or stroke is also not there. So issue is frequent pain crisis, and as an adult, he is also having a chronic pain syndrome that is actually compromising the quality of life. So he used to get admitted every 3-4 months for last 4 years. And every admission is around 5 to 10 days duration. Started with hydroxyurea, dose escalated, no response, developed leg ulcer. We started with L-glutamine, that is of course the non-pharmaceutical grade. In addition to the hydroxyurea, in 2019 had severe pain crisis that did not respond to any drug, so we did an exchange transfusion. In March 2021, started with crizanlizumab, 5 mg per kg IV infusion. Hydroxyurea we continued. tolerance was good. There was no significant adverse events. One pain crisis in May 2021 did not require any admission. On home treatment, he got cured. Immunized with COVID vaccine in September 2021. But because of availability and accessibility, he discontinued crizanlizumab on October 2021, presented to the emergency department on 14th December with 2021. We managed accordingly, and crizanlizumab was restarted on 30th December 2021. So this is the longest experience I have with crizanlizumab. And second case, that is also to the same grade with control, good pain control. And he is on crizanlizumab for last 4 to 5 months. So this much is my experience. So I'd like to discuss any other issues during the discussion. Thank you, sir.
Thank you so much, Dr. Ashutosh, for sharing your experience. Fantastic benefit to your patient. Move on to Dr. Bharat Parmar, Professor and Head, Department of Pediatrics, Zydus Medical College and Hospital, Dahod. So Dr. Bharat, your experience.
Good evening, sir. I am very thankful to Agrawal sir giving me opportunity to highlight my views regarding the crizanlizumab in 5 patients at my institute. May I share my slide?
Yeah, please go ahead.
Visible?
Visible.
So experience treatment with the injection crizanlizumab in sickle cell anemia.
Lost your slide now.
One patient, 18-year-old female child with no morbidity, and I am monitoring. There is a hemoglobin, PCV, blood count, CRP, renal function, and liver function every 4 weeks. 2 patients. Second patient, 23-year male child, no comorbidity, and also I'm monitoring this hemoglobin, PCV, total count, platelet count, VOC. It is on hydroxyurea therapy, and also what is the frequency of hospitalization, and this injection crizanlizumab since 1 year going on. Third patient, there's a 24-year-old male comorbid TB on regular treatment. Fourth patient, there's a 36-year male patient, no comorbidity. Fourth patient are also monitoring all blood markers and clinical outcome, hospitalization. Fifth patient, there's a 37-year-old male child, no comorbidity, and first stage hypertension and on medication. Concluding remarks of this observation, in this study, 3 age group included: 10 to 19 years, 20 to 29 years, and 30 to 39 years. And selection of these patient VOC more than 3 to 4 per year in adult patient. In these 2 patients are on a hydroxyurea, and 3 patients are there is a no hydroxyurea. All patients monitoring every 4 weeks with CBC, CRP, LFT, and RFT. I am treating these 5 patients with crizanlizumab more than 3 to 4 VOC at Zydus Medical College since 1 year. And after started injection crizanlizumab 5 mg IV in 30 minutes on a first day, and then after 2 weeks, then every 4 weeks this therapy. After 2-month therapy, there is a decreased frequency, duration, and severity of VOC. And after 6 months therapy, there is a no VOC. outcome of this therapy, blood marker, hemoglobin and PCV stable after 6 months of therapy, and CBC, platelet and CRP were normal after 6-month therapy. And clinical outcome, after 6 months, there's a no VOC, no hospitalization, no blood transfusion, and no infection. And on organ function, every 4 weeks, there's a liver function and RFT done, they were normal. And short-term complication, there's no side effect of these drugs. And the long-term complication, the compliance was good. No abstention from study and the work because no VOC. And all patients failed after therapy. For merits and demerits of this injection, crizanlizumab required long-term treatment and follow. Thank you.
Thank you so much, Dr. Bharat Bhai. Large experience. Some of your patients were not on hydroxyurea. We'll come back to that discussion a little later on. Now I invite Dr. Dibandhu De. He is DM Clinical Hematology, European Hematology Association certified, previously at CMC Vellore, Singapore General Hospital, and now consultant hematologist and hemato-oncologist at Balco Medical Center, Naya Raipur, Chhattisgarh. So over to you, Dibandhu.
Yeah, thank you, sir. I would like to share my slides. So are my slides visible?
Yes, Devan.
Yeah, so I have very few patients on crizanlizumab only, and I would like to share one of the single patient case study. So as you all know that India is in the part of the sickle belt, and Chhattisgarh is actually in the middle of this sickle belt, and we have a lot of sickle patients. So this patient is a 24-year-old male presented with a pain in both lower limb with limping, and he was unable to bear weight. He was diagnosed as sickle cell homozygous at the age of 6 years, and in the past history, he had repeated episodes of acute pain, both in the chest pain as well as the hip pain. For the last 10 years, he is actually stopped playing, and for the last 1 year, he has become bedridden and cannot even walk. No history of blood transfusion for the last 6 years, and his hemoglobin was maintaining around 8 to 10 gram per DL during this last 6 years periods. So these patients had a mild anemia, no jaundice. There was an ulcer on the right leg. Vitals was stable, but there was a painful hip joints, more in the right, extremely reduced range of motion in both the hip joints. And the family history, there was a similar problem, sickle cell disease, in one of his cousin who died at the age of 30. And the MRI of the hip joint showed that there was bilateral hip avascular necrosis, more advanced in the left side, and there was also bilateral hip joint effusions. So there was a chronic hip avascular necrosis there. On hemoglobin HPLC, the sickle cell percentage was 68%. So how do we treat these patients? Because there are lots of options, and we had discussed this with the patient and the family. He was actually staying at 120 kilometers away from our hospital. So there was a very difficult for him to come to a regular visit. There was no facility of transfusion or exchange transfusion in the nearby to his area. There was a large infected leg ulcer, which was, that's why we are skeptical to start hydroxyurea. And patient doesn't want to go for surgery because he was actually prescribed a hip replacement for his avascular necrosis. So we started this patient on crizanlizumab in 5 milligram per kg every 2 weeks for the first month and then monthly once. The response was that no acute pain episodes since then. The patient has continued this therapy for last 1 year. There was no single acute pain episodes, and the chronic pain that was there, that also started to decrease from 2 months onwards. Patient can now walk and bear weights. He has now restarted his own business in post-pandemic period at his hometown and continuing this therapy. Actually, right now he is more than 1 year. We had a plan to repeat an MRI hip joints after 1 year to see if there is any change in the avascular necrosis or in the pathology of the hip joints and whether he needs a hip replacement till now. So that is what our experience. Thank you.
Thank you, Dr. Devendra, for sharing that case. Fantastic. His hip has improved. Let's hope the MRI also shows changes. Next is Dr. Rita Saxena, Associate Professor, Department of Medicine, Gandhi Medical College and Hamidia Hospital, Bhopal. Over to Dr. Rita.
Thanks for the kind introduction, sir. I'm thankful to Mumbai Hematology Group and Novartis for making me part of this program. I would like to share my screen now. So is it visible?
Visible.
So starting with, I will be telling about my experience with crizanlizumab in sickle cell disease. See, we all know sickle cell disease is most prevalent across central India, and Madhya Pradesh has the highest load of sicklers in India, and prevalence of carriers among different tribal groups varies from 1% to up to 40% in certain pockets. At Gandhi Medical College, we cater to patients from all over Madhya Pradesh. Total sickle cell disease patients visiting our OPD is around 400, and we have around 40 to 50 patients visiting per month in OPDs and around 10 admissions in a month. Most of these admissions are actually for VOCs. So they are presenting complaints in more than half of the cases in OPD as well as IPD. We have seen all types of complications which are described in textbook in these patients. And we routinely use hydroxyurea along with other symptomatic and supportive treatment for these patients. But we all know we still have a lot of unmet needs in sickle cell disease. The currently available curative treatment, that is transplant, is not accessible to many. Many patients still suffer from VOCs in spite of being on highest possible doses of hydroxyurea. Significant numbers have chronic complications and organ damage. They have increased mortality even on treatment. A lack of compliance and intolerance is also quite common with hydroxyurea. So there was no new drug after hydroxyurea for a long time. After that came crizanlizumab, which is both DCGI and FDA approved to reduce the frequency of VOCs in sickle cell patients over the age of 16 years. Now coming to my experience, thanks to Novartis, their familiarization program, we have been able to use it in 5 of our patients. The first patient that we had was a female who was a lab technician at our hospital only. She was, I think, the most sick patients who would come every few days to me for VOCs, aches and pains, and she would be also very frequently hospitalized for these complaints. She was on hydroxyurea, compliant, taking it. In spite of that, she had a lot of problems. So we decided to start her on crizanlizumab, discussed with her, she agreed to it, and since last 11 months, she's receiving crizanlizumab. Following her, we gained a lot of confidence, and then we started on 4 other patients. So what are my observations? Crizanlizumab is safe and easy to administer. None of my patients had any infusion-related reactions till death. We usually give it under observation. They have to stay in hospital for 2 to 3 hours. And I have been monitoring their biochemistries, and I do not find any hepatic renal or other toxicity. Regarding efficacy, the VOCs have significantly reduced more than what the literature says. So the first patient from 10 to 12 VOCs in a year now has reduced to around, she had 2 in the last 11 months. In other patients also, there is significant reduction in the number of VOCs. Another important thing that I would like to point is patients are happy because their daily aches and pains have improved. And they all say their quality of life is undoubtedly better than before. Hemoglobin has been stable, and I feel it's better, at least 1 or 2 grams better than before. There are no studies to support this, but this is my personal observation with my set of patients. There is a patient who stops hydroxyurea off and on in spite of repeated counseling, and he is also doing good on crizanlizumab. But at the same time, I would be looking forward to more data, real world experience on crizanlizumab. Right now, we do not have any data on role in acute VOCs. At the time of admission for acute VOCs, we would like to have more data on long-term organ protection, mortality benefit, quality of life data is also important to be gathered, effect on transfusion, children, pregnancy, and lactation. I will be a little concerned about its effect on immunity, as fever and influenza were the only adverse effects significant in trastuzumab army sustained trial, but I have not observed any such effect in my cohort of patients, and I would be looking forward to making it accessible and affordable for long-term use. Thank you.
Thank you so much, Dr. Reevathi. Another large experience. Dr. Seema Bhatodekar is our next speaker. She's Director, Department of Hemato-Oncology and Bone Marrow Transplantation at Bhailal Amin General Hospital, Sterling Cancer Center, Vadodara. Seema, you.
Thank you, Dr. Agarwal. I'm at the outset thankful to MHG as well as sir for inviting me and giving me opportunity. So Sickle is, so can I share my slide?
Please.
Is it visible?
Visible, just slideshow mode.
Yeah. So Sickle is always near and dear subject for me because I'm practicing in Baroda, and we have a lot of patients of Sickle coming from Panchmal district, and that is a huge belt starting from the from Bharuch, Ankleshwar to Dahod, and to some extent I get patients from MP Dhar also. So this is a single center experience. As has been mentioned by previous speakers, that hydroxyurea is a mainstay therapy, and we are patients are doing well on it. But there are certain patients who are not either tolerating hydroxyurea or there is a failure to treatment. Like they are 15 to 20% patients, and I have an OPD of more than 800 patients.
You lost your.
Yeah. $800 patients of sickle cell, but they all of them are not affording because they are from the tribal region, and thanks to Novartis familiarization program, they have given this Zanlizumab free of charge to these patients, some of the patients, and the patients who were included in this program were all were on hydroxyurea and supported treatment, but in spite of hydroxyurea, they were having significant morbidity in terms of frequent VOCs and in breakthrough complications also.
Seema,
and they were all desperately waiting for.
Slides are not visible. Huh?
Slides not visible.
You want Kalpesh to put it up?
Yeah. Yes.
Yeah. Now we can see the slides.
Yeah. So, so all these patients were on hydroxyurea on supportive treatment, but were having significant morbidity in spite of maximum tolerated dose of hydroxyurea in terms of recurrent VOCs and breakthrough complications, and they were all desperately waiting for the breakthrough research molecule. And this crizanlizumab has been given to 8 of my patients as a familiarization program to Novartis. 6 were male and 2 females. CBC create LFT was done before starting the this therapy, and both these females were not pregnant, and adequate hydration was also maintained before starting the treatment. And every time whenever we give this injection, we make sure that hydration is good, biochemistry is good, and CBC and retic is must before giving the crizanlizumab. This we give as a daycare procedure. First 2 cycles given once in a 14 days as a loading dose, and followed by that the maintenance once in a 28 days was given. The dose given was 5 milligram per kg body weight in 100 ml over 30 minutes, and no pre-medical medications like Avil Hydrocort was given. Next. So what we observe in none of our patients, we observed any infusion related reactions, but post transfusion mild body ache and low grade fever was observed in 50% of patients, but that was managed with the only oral paracetamol, and that only 1 tablet of paracetamol has taken care of their mild symptoms. No serious adverse events were observed. Next. So these patients are taking crizanlizumab for last 12 months. Follow-up CBC shows normalization of counts, normal retic count, LFT improved, and creatine also became normal. So in sustained study, they have shown that none of their patients have shown rise in hemoglobin, or no change was seen in indirect bilirubin as well as retic. But somehow in our patients, our patient never have a hemolytic crisis. Most of these patients have a VOCs, and we have seen maybe because the VOC was prevented, and because of that their hemoglobin, retic count, and LFTs remain normal. We have never seen before treatment also rise in bilirubin, indirect bilirubin. The rise in bilirubin used to be only mild, up to 2 or 3, not more than that, like we get in a hemolytic. It's not the seen in Baroda. So significant, the most important thing is, as has been mentioned by previous speakers also, the significant comfort level has been achieved in carrying out routine daily activities. And all these patients, I mean, this was the first time I have realized that sicklers have so much of chronic pain that even doing the daily routine activities and course is painful for them. And getting relief from them is itself is a great relief for them, and they really come to the OPD, and they specially mention they are able to do their routine activities without pain. There was a significant improvement in chronic pain and decreased episodes of VOCs in last 12 months. Next. So what I feel, that crizanlizumab is a dream girl, it's a dream drug. It is going to be a game changer for sickle cell disease, because it's a once in a month, easy to use, no infusion related reaction, only 30-minute day care procedure, no marrow suppression or serious adverse event, and significant reduction in VOC episodes, organ damage, end organ damage. Definitely we will require long-term follow-up to see whether it is really preventing end organ damage or not. But the most important thing is, because they have a pain-free routine activities, it brings back shine and smile on the face of sicklers and bringing back to the normal life. Thank you very much.
Thank you, Seema. So shine and smile on the faces of the patients. Wonderful dream girl presenting dream patients. Dr. Vikas Goyal now, hematologist, hemato-oncologist, Sanjeevan CBCC, USA Cancer Hospital, Raipur. Vikas, over to you.
Yeah, good evening, sir. I am thankful to Agrawal sir, MSG, and Novartis for providing me an opportunity to share my experience of using crizanlizumab. Kalpesh, please share the slides. So I am practicing at Raipur, Chhattisgarh, where sickle is very prevalent, and I am able to use crizanlizumab in 5 of my patients. Today I will be sharing my one case. Slides are not visible, I think.
Kalpesh.
Should I share? Okay. So 17-year male patient who is sickle homozygous, he used to require hospitalization for a recurrent vaso-occlusive crisis, mainly acute chest syndrome, painful crisis, etc. And he used to get admitted 3 to 4 times a year. He was on full dose of hydroxyurea from last 8 months. So he was clearly having suboptimal response to hydroxyurea. And as patient was persistent to get admitted for VOC and occasionally require blood transfusion, we counseled the patient and relative for this newer molecule injection crizanlizumab, and they were agreed upon to use this molecule. Next slide, please. So patient was started on injection crizanlizumab at a recommended schedule and dose, and hydroxyurea we continued because he was not getting any side effects from hydroxyurea. And what we saw that he tolerated this molecule quite well. In my experience, nausea and abdominal pain was the only symptom patient reported. Now this patient is on crizanlizumab for more than 1 year, and he responded to this. His frequency of VOC reduced, and now he requires hospitalization only twice in 1 year, as compared to 3 to 4 times when patient was only on hydroxyurea. So in my experience, this molecule is well tolerated, effective therapy for patients who are suboptimally responding to capsule hydroxyurea alone. Thank you.
Thank you, Vikas. Dr. Abdul Mazid, would you like to do your presentation? We couldn't see your slides that time. Are you there?
He is not there, sir.
He is not there. Fine. So that completes all the presentations. Now we are open for the discussion. Anybody has any question for anyone, please go ahead. This has been a fascinating presentation, almost about 20 to 30 cases shared amongst 12 of you. And it seems an extremely positive molecule. Everyone has presented positive data, vaso-occlusive crisis, frequency, severity, chronic pain, everything come down, no adverse effects, simple OPD treatment. The story looks very fascinating. So questions, discussion, any other experiences? So if we don't have anything, we hand over to Dr. Saumil Modi from Novartis for his speech about Novartis' commitment to sickle cell disease in India. Over to Saumil Modi.
Thank you, sir. Thanks a lot. And are you able to hear me?
We can hear you.
Yeah, thanks. Thank you very much. Good evening, everyone, and really a pleasure to share the platform with such an esteemed group of faculty and panelists. At the outset, first of all, let me thank Mumbai Hematology Group, Dr. M.B. Agarwal, for organizing this event and turning back the spotlight on the critical topic of sickle cell anemia. For over 40 years now, Novartis as a company has been involved in research and collaboration for sickle cell, and we continue to invest in sickle, understand and pursue a comprehensive approach towards tackling the disease. Over the last 2.5, 3 years in India, while we've been doing a lot of work, right from healthcare system strengthening, one of the areas, and of course in your clinics, you see a lot of patients, but when we've started visiting across, one of the areas that we've observed is the last mile connectivity in terms of getting the patients to a primary healthcare center, or getting patients to the treatment centers. And that's where we've seen a lot of challenges that have come across in whatever limited understanding we have of this disease area in the last couple of years. So what we've been doing as a part of our overall strategy also is to do a lot of work around increasing awareness. At the same time, doing a lot of programs, like we worked on supporting a report by the Economic Intelligence Unit that examined the key elements of sickle cell in the country. Today, we've also educated more than 500 plus primary care healthcare physicians in Maharashtra and in Madhya Pradesh over the last 18 months or so, and work with the government very closely so that they're able to identify and pick up sickle cell at an early stage. And what we're also doing is ensuring early screening and detection in Chhattisgarh and Jharkhand, along with Piramal Swasthya through mobile screening vans as well. We've been working very closely with the tribal ministry in terms of the initiatives, and every time we meet them, the whole idea is that can you get us projects we're ready to fund, but get us projects which are implementable. So there's a lot of focus that's coming in from the government as well, as far as SCD is concerned. But as I earlier also said, there are some challenges in terms of last mile connectivity that we try to work in. Over a period of time, we've done a lot of studies. We committed to SCD research in India with various clinical trials as well as real world evidence studies that would help us to generate data. And today, the cases that all of you showed and presented are a true testimony. And we would like to make an effort to ensure that we collate all this data in a very systematic way. Our colleagues are currently working on health system strengthening projects. We're looking at partners like UNICEF and others who can help us to improve the last mile connectivity to ensure that there is a comprehensive access for sickle cell patients. We don't believe in temporary relief. but the overall ultimate game is complete treatment in STD management. Can we work with extreme successful healthcare models involving ASHA workers? This is an area that we've been discussing on for a very long time, but we'll continue to put in our efforts so that time and again, we can work towards that. There are many unanswered questions and unexplored territories as far as sickle is concerned, but I'm sure with activities like this, working together with stakeholders and physicians like you, we will be able to provide and build a comprehensive ecosystem for our sickle cell warriors. Thank you very much. And once again, I'd like to thank Dr. M.B. Agarwal for organizing this meeting and getting all the esteemed faculty and sharing their experiences as well. Thank you, sir. Thanks a lot.
Thank you, Kamil. And I think on behalf of Mumbai Hematology Group and also on behalf of Novartis, I'm extremely grateful to everyone who made this program so successful. Last 4 hours have been very, very enriching experience, especially the last session of 1 hour where the experience sharing from my colleagues from across the country, good number of cases, almost 25 to 30 of them, more than 1 year of experience, some of them reaching 1.5 years of experience, 5 to 10 cases at some of the centers. And what a tremendous molecule, what a tremendous relief. Such a phenomenon decrease in VOCs and the chronic pain, improving the quality of life of these unfortunate victim of not an uncommon disease, probably the commonest of the genetic disease in India and across the world. I think it's a human service being done by Novartis and all our colleagues. Thank you so much for sparing your Sunday evening on this World Sickle Cell Day. I'm really grateful to all of you for making this such a important educational event. Thank you so much and good night to everybody.
Thank you, sir. Thank you so much.
And thanks to our event management team for the flawless show. Once again, thanks to